Good evening, everyone. So I hope you're doing fine and your revision sessions are really going great. And today we are starting with dermatology. What I want you from all is interaction in the class so that you learn dermatology right away from the class itself. So almost 4 to 6 questions are asked every year, and I hope that you can crack them all in from the session of us today. So let's begin without any further delays. First, let us discuss about the basics of the layers of skin. So the skin is divided into the epidermis, dermis, and the hypodermis. So the layer which is below dermis is the hypodermis, then the dermis itself, and the epidermis, which is epi word means above. Then let us move to the type of skin. So you have two types of skin, the known hairy skin, which is present on your palms or your soles, right? So it is also called as glabrous skin. Whereas the part of body which has hair bearing skin is called as non-glabrous skin. Then for the layers of epidermis, so there's a famous mnemonic for it. Come, let's get sunburn. So with the cum, it's like stratum corneum. Then we have stratum lucidum with let's and stratum granulosum. Then the next is stratum spinosum. And the last one is stratum basale. So this is the order of the layers of epidermis from top to bottom. Then certain specific features you have to know about all the layers. The corneum, so with the C in it, it is keratinized. So this is having flat cells, as you can see in the image, and it is keratinized and the anucleated cells are present. So you can see in the image that there is no nucleus which is present in these cells. Then we have stratum lucidum. So the word L, lucidum. So lucidum, sorry, has L in it, which can make you remember the translucent cell layer, which is present in the palms and soles. So everywhere you can see there is L in this lucidum, lucent, and palms and soles. So that helps you to remember this. Then we have the granulosum. So the name itself suggests that it is a granular cell layer. So it has two types of granules, the lamellar granules and the keratohyaline granules. As you can see, lamellar granules gives this lipid component of the skin. So what is the function of lipid? This gives the barrier function of the skin. You know that you come across a lot of microbes every day, but you don't get infected, right? Because you have this skin barrier on yourself. Then we have keratohyaline granules, which have the filaggrin protein in them. This filaggrin protein has this filament aggregating protein. So, what is the role of this filament aggregating protein? Is that it helps in holding of the keratinocytes together. Then we have the spinosum cell layer. So, why the word actually the spinosum word has given? Because of its appearance, you can see it has a spiny appearance. So, from where the spiny appearance comes? So, you can see it is coming because of the desmosomes. What are these desmosomes? So, this is one keratinocyte and this is the another keratinocyte. So, one keratinocyte gets connected to the other keratinocytes, and this is helped by this desmosomal connections, and it is present in the epidermis. That is why intraepidermal, and between the cells. What cells? Keratinocytes. It is intercellular connection. So that is why it is spiny in appearance. And then we have stratum basale, where you can see the name for stratum basale is also germinativum. So this has a capacity to germinate. So it is a single cell layer and it is columnar, having columnar cells. So what is important, which has been asked previously, anyone who can tell what is epidermal transit time? Yes, I'm reading the comments. Maybe you can tell me. So any questions you have, we can take it in the end. A session might last for 3 to 4 hours. And let's continue with the session then. Normally, epidermal transit time is 28 days. I'm just waiting for your answer. Anyone who's knowing about this PDF, you can ask for, yeah, it will be enough for FMGE Jan 2026. Absolutely, that will be enough. Just combine it with your PYQs. Okay, and so let's continue. epidermal transit time. So as I told you, this basal, the lowermost or the innermost cell layer, it goes, and the uppermost is the corneum, as we said, right? So this time, it takes time. The cells from the basal, they differentiate continuously and then they go up to the corneum. So that takes some time, which is called as your epidermal transit time. So normally it is 28 days, but in psoriasis, very important, has been asked previously, it is 3 to 5 days. So this gets reduced. So that's what you have to remember for this. Then let us talk about the cells of epidermis. We have already discussed keratinocytes. So the keratinocytes, they actually make up the 90% of the epidermis, right? So this keratinocytes, the ectodermal cells, okay? And again, a K, keratin intermediate filaments are present in them. Now, the known keratinocytes. In non-keratinocytes, we have three types of cells. We have our Langerhans cells, we have our melanocytes, and we have our Merkel cells. Fine. Then let us discuss about each and individual cells. Where are the Langerhans cell located? So L Langerhans, L M. So you can remember like this, L M. So L Langerhans cells are present in stratum spinosum, and they are M again, mesodermal in origin and derived from the bone marrow. Specifically for Langerhans cells, you have to remember that they have Burbeck granules, which is this tennis racket appearances there for the Burbeck granules on electron microscopy. This is one point additional. And then what is important is that these are antigen presenting cell. So whenever you get any antigen, any infection coming from outside, it is just giving to the APCs, the antigen presenting cells, and then your immune response is followed. So this is the function of your Langerhans cells. So they are helping you to have this immunity. Then what is the importance of this? So there is a disease condition, Langerhans cell histiocytosis, where the markers of this is important. S100, CD1A, CD207, and Langerin are the markers. So Langerin being the most specific one because it is having an L. That's how you can remember. Then we have our next cell layer, which is, next cell in the non-keratinocytes, which is your melanocyte. So the melanocyte is, the name itself can make you understand. It is going to give you melanin, right? So where it is present in the stratum basal, and it is derived from the neural crust. So M followed by N, neural crust is the derived part, and the melanosome. So it contains melanosomes, which produces melanin, which gives your skin color. Okay, and the markers related to is S100. You don't have to remember because it's present in both. So what is more important for this is melan A. So it can help you to diagnose melanoma, which is the skin cancer, and there is another marker which is your HMB 45. PDF, you have to check the Telegram channel. Again, so many people are asking the same question. Please check your Telegram channel for the same. Then the Merkel cells. So the Merkel cells, you remember again K from here. It is again present in stratum basal, ectodermal in origin, has neurosecretory granules. So study with your physiology also this thing. Slow adapting, low threshold. So these are mechano. So K sound again is coming. So everything related to K. Merkel cells, basal, ectodermal in origin, neurosecretory granules, and has this mechanoreception function in the touch. So they have this cytokeratin, again K20 as their marker. So you can see here, they have this nerve ending. Why? Because they are going to give you this mechanoreception thing. Then dermo-epidermal junction, you just have to have some basic idea for, last few days before exam, that it connects to your stratum basal to the underlying dermis. So as we discussed that we have epidermis, then we have dermis. So this dermo-epidermal junction is going to the junction between those places. So this is this hemidesmosome keratin filaments. You can see the keratin intermediate filaments. So these are connected. Then we have lamina lucida in it, and then densa and sublamina densa. Then we have the last skin layer, which is your dermis, which is made up of 70% of collagen, which is very, very important for our skin. So papillary dermis, not from the exam point of view, that's nobody is going to ask you this basic, but more of the pathology thing. Papillary dermis and reticular dermis. We have two types of dermis. Reticular word itself means these web-like connections. So it is more thick in nature, dense, and has irregular margins, because the reticular word itself means that. So it gives structural support to your dermis. Then papillary is finer, it is loose and regular, and it supports capillary network and dermal papilla. Next, we have hypodermis, which is your fat cell layer. So you can see the fat lobules and the connective tissue in this one. Next, we move on to lines in dermatology. This is very, very important. The lines in dermatology. Anyone who can tell me what are these lines and these lines, the name. This has been asked a couple of times, so you have to remember this well enough. So, two things. This Langer's line has two L's in it. So it is it corresponds to the alignment of collagen fibers. So with two L's, you have to remember this. And what is the importance? So any surgeon is going to make an incision along these Langer's line. If he does that, the scar will not be that bad after surgery. So this is the importance of it, because it is in the alignment of the collagen fiber. So two L's can make you remember this. Again, you see it is more straighter in nature. Fine. So that is how you can compare it with Blaschko's, because when the image will be given, you will be confused only between Langer's and Blaschko's. Whereas Blaschko's, there is B in it. So keep the, keep actually checking onto the keyword. So the Blaschko's are embryological development corresponding lines. And as you can see, these are more spiraled like this. So you can actually make a B in this. So more spiral, because B itself word is very spiraled. Sorry, alphabet. Okay. So that's just a mnemonic to help with it. And a disorder, which is incontinentia pigmenti, occurs in the lines of Blaschko's. It occurs in that pattern actually. Then we move on to appendages and disorders. You have to you remember this as well, that we have apocrine sweat glands, where these sweat glands, they open into the hair shaft. So this is hair shaft, it opens into that. Then we have ecrine sweat glands, which is opening into directly onto the skin itself. We have sebaceous gland, which is more lobulated, as you can see, and it is also opening into the hair shaft. Then in the end, we have in the appendages, which is your erector pili muscle, as you can see here. Then we move to one of the important topics, has been asked previously, alopecia. What is alopecia? Very simple. Yeah, I'm happy. Just be engaged and keep commenting the keywords in the session, or just keep do lip sync and all wherever you're studying, so that you're actually involved. So alopecia is hair loss. Yes, Anirudh, absolutely. We have non-cicatricial or non-scarring type of alopecia, and we have cicatricial or scarring type of alopecia. So in non-scarring, we have to read about patchy alopecia, which is alopecia areata, as we'll see with the image as well. We have diffuse type of alopecia, we have patterned, and in the end, systemic alopecia, which is associated with SLE and thyroid dysfunction. Fine. And in cicatricial alopecia, we have papillosquamous type of, we have granulomatous, which is in sarcoidosis, we have connective tissue disorder. We'll see them in the systemic diseases when we'll move ahead. And the infections, which is a tinea infection, that time also we'll see the scarring alopecia. But for now, let us move towards the non-scarring alopecia. Ready for it? So the alopecia areata, right? So let us start with the alopecia areata. This area, why area? It is well defined. Fine, it is well defined. As you can see, the margins are well defined, and the place from which, so there's a particular area from which the hair has been lost. So complete hair loss is there. So this particularly, you have to remember well defined word for it. So it will be very easy. It is just a spot diagnosis. You can easily diagnose it on the image. Then we have trichotillomania. So mania obviously can remind you the maniac people, the people with this compulsive disorder of plucking hair. Okay, so they have this habit of plucking their hair. They pluck their hair. So because of this plucking, what happens is there occurs a perifollicular. Around the hair follicle, you will get hemorrhage. Okay. So that's one thing which is important and gonna help you to diagnose trichotillomania. And then when you pluck, sometimes half of the hair is plucked. That gives you exclamation mark sign which can be seen. Now, when someone is plucking, it's not necessary that the whole area's hair is plucked. So that is how you can differentiate it from the alopecia areata, where the whole area is having no hair, but in trichotillomania there are hair which are present in between. So that's how it is. Then trichobezoar is one thing which is associated with trichotillomania. Please study it in association with your surgery. So people they pluck, they eat their hair, and this becomes a ball in your intestine. So there's an image famous which you probably might have seen as well. Then we have androgenetic alopecia. So I've taken Salman Khan's Your Sallu Bhai pictures. Please don't forgive me for this. And basically, this is frontotemporal recession, which I wanted to show you. Earlier, Salman Khan used to have very dense and thick hair, but then what happened? Like he aged because of androgenetic alopecia. There is a frontotemporal recession. So you can see this is a frontotemporal recession which is happening. And apart from this, in a male, there is balding of vertex, which you can see. So most of you have been already aware of androgenetic alopecia. Then versus in women, what happens in women? Now, women, they will not have any hairline which is going backwards. Fine. Hairline is maintained. That is how you can actually do the differential with the androgenetic alopecia in female than the men. And there is a diffuse hair loss. So the hair thinning happens in women. That's how it should be. And now we move to sweat glands and its disorder. We have merocrine, which has ecrine secretion, and we have apocrine. So when we talk about merocrine, there is a secretion of vesicles. Secretory vesicles secrete their secretions, but the cell remains intact. On the other hand, when we talk about apocrine, this apo word is for apex. So the apical portion, you can see the entire apical portion gets pinched off, and then that is how it is going to secrete its secretion. So the ecrine glands, they have merocrine secretion, and the blockage you can see in malaria, on the skin. More importantly, you have to remember about the apocrine malaria, which is usually seen in the armpits. And the apocrine gland, the secretion which apocrine glands they give, everyone has a particular body odor. Why it is there? Because of the apocrine gland secretion. So whenever the duct of apocrine gland gets blocked, we get apocrine malaria, and this is how it looks. Then we move on to acne vulgaris. So this is very, very important, I'll tell you. This is a previous FMG question. Microbe implicated with acne vulgaris. Can you tell me? Like, I'm just waiting for a response for this. Yes. Thank you, Anirudh, for answering this. No, you should know. It's Proprioni bacterium or QT bacterium acnes. So don't forget this. Once asked in FMG or NEET PG can be asked again. Okay, so the name of the bacteria is probably cute, but it doesn't let people stay cute, because acne actually gives a very bad psychological impact on patients. So just don't study it for exam, but also just be very kind to the patient of acne, because they actually have this psychological issue because of the appearance, specifically in grade 4 acne. Then this is also important. The grading is important. The treatment is important. The microbe implicated is important in acne. So for grade 1 acne, we have open and closed comedones. Fine. So comedonal acne, the comedones is your special lesion of grade 1 acne. You can see that we have this blackish discoloration. So this is because the air it gets oxidized and gives this black appearance, leading to the open comedones, and this is more white in uh, nature. So this is closed comedone. Then we have the grade 2 acne, which is having more lesions like papules, as you can see. And this is grade 2 acne. Then we have pustular acne, where you can also see that the acne has certain erythema, and there is a pus like yellow thing which can be seen. So this is pustular acne, and it is grade 3. So you should be able to diagnose all three acne, okay, on the basis of image. So image based thing can come in the exam. They can ask you treatment for acne, they can ask you the bacteria associated with it, the microbe implicated, and then the last one, which is your grade 4 acne, is nodulocystic. So you can see that it is giving, it's the most severe form of the acne, it's giving you cystic appearance and the nodules are formed. So I hope everyone is good for this. Rishi Mahala, please check the Telegram channel. You'll get it. Can we move ahead? Treatment Anirudh isotretinoin topical, yes, can be given for grade 4, but you can't give it for grade 1. So, treatment for grade 1, classically comedonal acne, you use topical retinoids. Okay. Please just be careful. Like, this is something which you should know. Topical retinoids, adapalene you can use, and the tretinoin you can use. Then another, you can use systemic antibiotics. You don't have to actually remember the whole names exact, but that will be enough for you. And then the third thing, for grade 4 particularly, if they ask you, if they give you this nodulocystic image in the exam and then they don't give you any history, grade 4, they have said just mark isotretinoin. Okay, this is oral retinoid. So this has to be taken HS. You take it in before bedtime. That is about the treatment. Anyone who didn't understand, please take this, consider this. This is important. Okay, isotretinoin cannot be given during pregnancy. And you have to do the DD, differential diagnosis with acne rosacea, and it is chronic inflammatory facial dermatosis. So look for some triggers. Certain triggers will be there in acne rosacea, whereas in acne vulgaris it will not be. So this is spicy food, sunlight exposure, alcohol intake, any hot beverages. So that gives you this acute kind of, and it has different types on the basis of morphologies, appearances. It is present on the face, most importantly. The first type is erythemotelangiectatic type, which you can see the dilation of the capillaries of the face, and there is flushing, facial flushing, and telangiectasia. The ectasia word means dilatation of blood capillaries, which you can see. So you will see the sun exposed areas are more involved in this. Then we have papulopustular type, which has a multiple papules. So you see that there is again yellow thing, which is your pustular kind is coming. So this has multiple papules, the papules being the pink reddish one and the pustular kind of variant. So it is papulopustular type. Then we have next, which is phymatous type and the rhinophyma. Potato nose, you also studied in ENT. This actually gives you what? Thickened skin. So you can see that the nose, which you can see the nose has this thickened skin, and there are surface nodularities. You can see the nodules can be seen. And it is because of the sebaceous glands being hypertrophied and fibrosis which is occurring. So you just, I don't think so that you'll find it difficult to distinguish it from the acne. Then you move to nail disorders. Terry's nails. So the word Terry reminds me of the Jerry. You can see, you must have watched this cartoon character. Fine. And what happens? You see the eyes of the Jerry. The 90% of this remains white. The 90% of the nail is white, and the rest 10% as the iris of the Jerry is dark, the pinkish reddish one. So now why I've taken this image, this big belly of Jerry is going to remind you ascites, okay, which is seen in chronic liver disease. So these nail findings, actually, they are associated with certain disorders. Terry's nails are found in patients of chronic liver disease. Then you have Lindsay nails. Lindsay is half and half nails. So most of you, the FMGs, at least I know that you might have had this chocolate, Lind chocolate. So it has 50% cacao. Why? This is going to remind you of half and half nails. 50% part is white and 50% is dark. Okay. So you eat chocolate, then you eat sugars. That means you get diabetes. You don't actually get diabetes, but that is just for your mnemonic. So that is going to make your kidneys fail. So patients of chronic renal failure is going to present with such kind of nails, which is your Lindsay nail. Okay. Again, I'm telling you, it's not going to give you diabetes. It's just for your mnemonic. Then we have Mies line. Mies line, these are white bands on your nail, which you can see, white lines. Now, this S is going to remind you or remember or recall you with this chronic arsenic poisoning. So, this is rapid revision, guys. One thing. So, you have to pick only the points which is going to retain in your head. Most of the information cannot get, you're just few days ahead your exam, you can't remember everything. So you remember Mies S and arsenic S, arsenic poisoning. Then you have Merck's bands. Fine. You can see that these are also white and pink in the middle. So these are paired. While your Mies are like single white lines, these are bands which are paired. So this B again is going to remind you of hypoalbuminemia. So condition which is hypoalbuminemia is going to have Merck's bands. Next, you move to infectious disorders. Very, very important. You read it in conjunction with your micro lectures. So that is going to help you to retain that more. So now fungal infections, when we I hope everything is going good. Kindly focus on studying right now, and I'll take up your questions in the end only. Right now, we have to focus more on the content because we have to actually, yes, Bhuvan, you're right, absolutely right. The Pityriasis word is going to remind you of scaling. So, Pityriasis means scaling. And the versicolor. So the versi is variety of colors. Why variety of colors? They have different variants. There is one which is hypopigmented variant where the pigment production is reduced, and there is one which is hyperpigmented variant. So hypopigmented you often see in OPDs. It's little commoner. Hyperpigmented is little less common. So these are macules, which you can see the macules which are present, the hypopigmented one. So important is it is caused by Malassezia globosa. Then furfur, like globosa is more common. Most common site being trunk. So the image, if this comes in exam, they'll give you the trunk image mostly. And investigations, you do 10% KOH mount, very important, and spaghetti and meatball appearance. So when you make up this 10% KOH mount, you get this kind of an image where you can compare it with spaghetti and meatball, where the spores, fungal spores, are compared with the meatball and the short hyphae of the fungus are compared with the spaghetti. Then we move to treatment. Treatment, fungal disorder, azoles, everyone is knowing about this. So you can use topical azoles. You can use selenium sulfide, which is also topical ointment. And systemic, you can go fluconazole, itraconazole, you can give anything. So, but you focus more on the image, and that would be enough for your exam. Then candidiasis, I guess all of you know. Oral candidiasis is the one thing which we are studying right now. You can see this baby. So, what is important for you to take away for oral candidiasis is that the white pseudomembranous plaque can be rubbed off in candidiasis, but there will come, like we'll study shortly, a disease where we cannot rub off this white plaque. And this is the presentation. So mostly image-based spot diagnosis can come. Now, the second type of candidiasis, candidal infection, is candidal intertrigo. So it is present in places like, probably under the breast or in the thighs, because this is getting wet because of the sweating and all, so it doesn't get much of air. So you can see red macerated plaque in this condition. And you can also see some satellite lesions. So some satellite lesions will be seen a little away from this red macerated plaque. So this is wet. So if you examine with your gloves, this will be wet to touch. That's how you can diagnose candidal intertrigo. Then the candidal balanoposthitis. Look for history of diabetes in these patients, because they are going to have this is associated with diabetes mellitus. So in OPD, it comes like a 60-year-old male who's coming and been on anti-diabetic drugs for 20 years, and he's just not a controlled diabetes case. So that in those people you can find it. So they have radial cuts like this and fissures. So this is the classical sign. Itching is always there in them. And it is also give itching and burning. Both things will be there. Then we have dermatophytosis, the tinea infections. Again, tinea, fungals, azoles are something which you can give in addition to azoles, where azoles are like the tinea is resistant to azole, then you can try terbinafine. So the known inflammatory type of tinea capitis. So cap is for the head region. Okay, so it has black dot variant, the endothrix version. So it has tonsurans and violaceous. So there will be these are the tinea. So if please kindly study this with your microbiology. That will help you a lot, because this is like overlapping topics. So before exam, if you study all together, it's gonna be very beneficial for you. So a child with patchy alopecia and broken hair, you will see that. So when you magnify, you can see that there are black dots which are appearing. So the broken hair is going to be seen like this black dot type of. So that's how you can see and diagnose this. Then we have the gray patch or ectothrix variant, where it is Microsporum canis. So this child, you can see he has gray scaly lesions. So you can see that silvery scales are present. So that is characteristics of your gray patch or ectothrix variant of tinea capitis. Okay, so this is the child with patchy alopecia. Then we move next, the inflammatory type of tinea. It has the Favus variant. So this crusting which you can see on this patient, this is called as cutula. Okay, so that is tinea schonelleni infection. And then in the end, we have the Skirion variant, where, I've taken this very famous Shin Chan cartoon. So, that Shin Chan used to have this pet dog, right? So these kind of child which come with this Skirion finding of tinea capitis, they have history of exposure to pet dog. Fine. And then you remember that the mother used to beat Shinchan and he used to get this boggy swelling. So this boggy swelling on scalp and easily pluckable hair. So these images must remind you of this history. That kind of picture is going to come. This is the boggy swelling which can be seen. So this is the chorion, and the lymph nodes are also involved here. Okay, because it is inflammatory type. Then we have tinea corporis. So the word corporis, corpora means the body. So this is going to be present on anywhere on your body. So what is classical about this? That this plaque, which you can see, the corner is raised. The margins of this plaque is raised, and this is an annular round plaque. And there is a central clearing which is there, and this is associated with itching. Okay, so this is caused by Tinea mentagrophytes and Tinea rubrum. So I hope this is very easy to diagnose. The Tinea corporis, very classical finding is there. The annular plaque, the borders of this plaque are raised, okay, and very itchy it is. So this is a PYQ, Tinea incognito. When you come across Tinea incognito, look for steroid application. So people sometimes, India is a country where people just go to the pharmacist and ask, like, I've got some itching lesions, just give me some treatment. And what the pharmacist knows about it, nothing mostly. So he will just give you steroids, and that is going to change the appearance. So classically, it should be like this, tinea infections. But in people who have probably used steroids, and the history might have been given to you in the question, so that is going to change its appearance. So why incognito? Because we cannot recognize what is it. It is not classically appeared. As you can see, this had raised margins, but this is, you can't actually diagnose by seeing this. Okay, so this is not having any clearing which is present in the center. It is not annular plaque. It is diffuse scaling is the characteristic finding which you can see, and incognito because you cannot actually recognize it. So important for this part is steroid application. History you will be given like this. Then we have tinea cruris, the jock itch, also called as dhobi itch. Okay, this again is going to come like the peripheries are erythematous and raised with central clearing. Then we have the tinea pedis, athlete's foot. So these are mostly asked as spot diagnosis questions. So you can they're like mostly similar looking. And itching is something which everyone is going to complain. The patient always complain with itching. Then we have onycho word for the nail, mycosis, the fungal infection. So you can see there is a yellow discoloration of the nail plate where you can see this thickening hyperkeratosis of the nail plate is happening. And you can also see the tunneling. So these are the characteristic findings of the onychomycosis. Next, we move to the fungal infections. The subcutaneous mycosis, sporotrichosis. I hope that you are aware and heard of this condition before. It is rose gardener's disease. So a history, a farmer or probably someone who's working in a garden. So that kind of a history for sporotrichosis will be given. It is caused by Sporothrix chancri. And what kind of lesion is there? So it is a nodulo-ulcerative lesion. And classically, it is along the lymphatics. It is seen. The lesions are seen, and this asteroid body is seen in them on histopathological examination. That is all you need to know about sporotrichosis. And then we move to mycetoma. So when we talk about mycetoma, it can be because of there are two etiologies. One is because of the fungal infection, and other is because of the bacterial infection. So the fungal infection, Madurella mycetomatis and Grisia, going to cause this, and then the antifungals is the treatment which you have to give. And in bacterial, the actinomycetoma also, it is also known as actinomycetoma. This is going to be caused by the filamentous bacteria, your Actinomadurae, or the Nocardia species, or the Streptomyces species. So what is the treatment? Of course, amikacin and cotrimoxazole. So they have this discharging sinuses. You can see that there is pus-like discharge which is coming out, and the granules, specifically for eumycetoma, the granules which will be seen in the discharge will be black in color. So they have these nodular regions. You can appreciate it well. And overall, it is a tumor-like swelling. So this kind of features, you will be seeing that in them. Next, we move to the chromoblastomycosis, also called as your verrucous dermatitis. Now, this word verrucous is like your cauliflower. Like what I wanted you to remember, like from here, this is the mnemonic, like chromoblastomycosis. So, will remind you of Krishi. Okay, so this Krishi. So, someone who's a person who's having history of vegetable trauma, probably a farmer. Okay, so blastomycosis, this brinjal should remind you of blastomycosis. So the word chromoblastomycosis, and this is how it presents: a verrucous plaque, like which looks like cauliflower like. Okay, so they have black dots on surface. If you magnify and appreciate it later in the PDF, then okay, what is the investigation of choice? Again, 10% KOH mount. The scales which you see, you scrape off and you put it on mount, like make a mount of it, KOH mount. And this is going to give you brown, round, thick wall bodies, as you can see, which is also called as medlar, sclerotic, or copper penny body. So it looks like a coin. That is why. So sometimes they just give you this image as well in conjunction with the image of the skin. Okay, so this is caused by the pigmented fungi, which is your Fonsai, Pedrosi, or Filiaphora verrucosum. Nobody's going to ask you the name of the fungus. But yeah, image space can come. It can be associated with this image. It can come from your microbiology side as well. So just study it in conjunction with that. And let's move to the viral infections. I think orolabial herpes, most of you have been like aware of this. You probably have seen it. So the HSV1, classical about this herpes infection is the vesicles, and these vesicles are present in a group. So the vesicles are shiny. So if the patient comes in OPD, you try to put some torch and it will shine. So that's how you can diagnose the cold sore or the grouped vesicles of your herpes, orolabial herpes. So it is found around the lips only. Then we have next is your chicken pox, which is your varicella zoster virus. And the infectivity of your chicken pox is till the lesion's crust. More classical about is this rose dewdrop pattern. So if you can see that there is this dewdrops which are present on the rose petals. So there is an erythematous pinkish area on which this drop-like vesicle is seen. So this is the classical lesion of chicken pox. Then when this chicken pox, this reactivation of what? Can anyone tell me? Reactivation causes herpes zoster, right? Where does it hide? Anyone? Your varicella zoster virus. This impetigo, honey crust, and everything, these are different things. These are in your bacterial infections of skin. Wait a little. Yeah, herpes zoster, right? Pranay, it is also called as shingles. It is unilateral and dermatomal in distribution. So one thing, this is a very easy to diagnose condition because this is not going to cross midline. So it is present on one side of the body. So unilateral in distribution, and one particular dermatome will be affected. So the complication which you will get after few months of this infection, people will come with post herpetic neuralgia. So they'll come and say it is kind of a sharp shooting kind of a pain which will be there. Then you have oral hairy leukoplakia, which is caused by the Epstein-Barr virus. For this, you look for history of HIV infection. Now, the differential diagnosis, and I told you while I was teaching you something that this this cannot be rubbed off, right? Which lesion, this white kind of lesion, the vice this white corrugated plaques are present here on the lateral border of tongue, as you can see. Okay, but this cannot be rubbed off. This is very classical for your oral hairy leukoplakia. It can come as an image based question again. And anyone, this cannot be rubbed off, but we just read some time ago same white plaque but can be rubbed off. So because you have to probably differentiate between the two conditions. The oral thrush candidiasis, which we read. Okay, if you knew the answer, good enough. But if you don't, just revise it one more time. Yes, Bharat, you're right. Oral candidiasis. That we can, when we scrape it off, that can be rubbed off. While oral hairy leukoplakia, this white plaque cannot be rubbed off. Then a PYQ again, Kaposi sarcoma. So caused by HHV8 virus. So you have to know this purplish plaque or nodule which is present. So this is purplish in color, and it is an AIDS defining illness. So if you find someone with a Kaposi sarcoma, which is a low grade vascular tumor, that means the person must have been infected with HIV. Yes, Shankar, you're right, absolutely. Then we move to molluscum contagiosum. This is caused by the pox virus. It is a self limiting condition. So even if you don't treat it, the patient will be fine after some time. So what you do is one thing that you have to be able to make a spot diagnosis in this. And you can see that there is this dome shaped appearance, which you can see with a central umbilication, which is there. Okay, and it is again pearly white. You can see it appears pearly white in nature. So the color is pearly white, and there is a central umbilication depression which is seen, and the shape is dome shaped, the papules. Fine. Of course, this one more thing, which is your pseudocobbinous phenomenon, which can be seen. So what is that? So when you kind of traumatize or scratch your skin, it is going to come to the areas of scratching, like the lesions will come over there as well because of the auto inoculation of the pox virus. Then the molluscum contagiosum virus 1 is going to be present in the children. So I is going to remind you of 1, and D is going to remind you of 2, MCV2. And in adults, it is more like anogenital involvement. And from microbiology, you can see Henderson-Peterson bodies are present on histopathological examination of them, molluscum contagiosum. Then we move to next, which is your common warts or verruca vulgaris. So this is HPV virus 2 and 4. What is HPV? Anyone? I hope you have a certain knowledge of all subjects when you're coming for rapid revision sessions. But these are the most important takeaways which you can just get from like 1 month before the exam. Human papilloma virus, yes, absolutely. So this is a common wart condition. This appears like mostly they'll give you this kind of an image, and they can probably ask you an image based question of verruca vulgaris. And vulgaris word itself in dermatology means most common, which is present commonly. Okay, someone is asking me to increase the pen size. Let me try that. Topical salicylic acid. You can give it, just put salicylic acid, and electrocautery can be done. Cryotherapy for their treatment can be done. But remember it as IBQ, most likely. And then the hand, foot, mouth disease, which will have vesicular lesions. And these vesicular lesions will be present on your hand, on the baby's hand, foot, and around the mouth. Then we have parvovirus B19 disease. And in this, if you remember the Paro of Devdas, so she was crying because she was slapped, not literally, but I want you to remember this. And she's known for the most beautiful eyes. The fifth disease, erythema. So EI can remind you of erythema infectiosum. So this is caused by your parvovirus B19, and this has your classical malar erythema. So this baby has your erythema infectiosum, the fifth disease, and you can also see he is lying in a state where B can be seen. So this will remind you of parvovirus B19 disease. So slab cheek appearance, you can appreciate that, which is there on the face, and the reticulate net-like rash present on the abdomen of the baby. Yeah, I don't know who slapped her, but all I wanted you to remember is mnemonic. Then your ectoparasitic infections, scabies. This has been asked previously, again caused by your Sarcoptes scabiei var hominis. And what are the clinical features? You look for nocturnal itching, very classical, and positive family history. So you will see all the siblings are coming together complaining of nocturnal itching. Or maybe sometimes if a child is going to school, all his friends have the same nocturnal itching thing. And very classical is the web spaces get affected. So excoriated papules are present in the web spaces. Burrows are present, which you can see. And there's a circle of Hibra, which is there, where it involves the 8 places: web spaces, medial, wrist, forearm, arm, axilla, nipple, and umbilicus, and the genitals and the groin. So these are all the places where you can find. So when the patient comes, you can examine him and the lesions will be present there. What lesions? The excoriated papules and the burrows. So burrows are very classical. These are called as the special lesions of your scabies. So you can see burrows here as well. So face is spared in adults, but in neonates it's not spared. Why in adults? Because the sebaceous glands are active in adults, so the sebaceous secretions won't let the pathogen grow here. So what you can give them is a 5% permethrin cream weekly, and ivermectin oral you can give to them. Then you have infantile scabies where the face is involved, because in them the sebaceous glands are not still developed fully, and the vesicles are present in palms and soles, as you can see in the infants. So that is infantile scabies. Then sometimes you can see the crusting is present. Okay, so the crusting feature is classical. So this crusting will be seen in, which is also called as Norwegian scabies. So this is where will be present where in the look for immunosuppression history. So patients of HIV or Hansen's disease, they will have very weakened immune system. So they will not have itching, because itching happens when your body is throwing up the immune system is active and you're getting inflammation signs. But in them the immunosuppression is not going to cause the itching, so there is minimal itching which is present. Then you have pediculosis. Yes, Shankar, you give permethrin cream to them. Pediculosis corporis vagabonds disease, also called as. So people like nomads or who doesn't take bath in time. So in them, the seams of clothing, they have this pediculous infection, like the that feeds on host, and lot of itching is there. So what you can examine in the patient is the signs of excoriation. So excoriation will be the lesion which you can see on the skin, and that is enough for this. Then we move to Psoriasis pubis. So this is the this will be seen, the site where it is involved is lower abdomen. So it is the skin lesion is called as macula cerulea. It's not very often asked, so you don't have to focus more on it. Pruritus is always present in all pediculosis infection. And then the capitis itself, so the cap, right? The head louse is there. Head louse is very common, so you all have are aware of it. So now we move to more important one, the animal hookworm larva. So this is migratory skin lesions. So the larva infests and it migrates. So you can see the cutaneous larva migrants. This is the animal hookworm larvae. What is that? Encyclostoma brasiliensis and Encyclostoma caninum. Now, this you will be given a history where a patient might be walking or might have walked barefooted, okay, on beach side. So there the patient gets infested with this larva, and it makes, you can see as if some larva has moved into the skin. So migratory serpiginous tract will be seen on the skin, which is very classical of your hookworm infection. Then you have cutaneous leishmaniasis. First, let's figure out the image. Okay, then what is there? And it is a nodulo-ulcerative lesion. You can see that the periphery is raised and erythematous. And then there is crusting which is happening in the center. You can see there is a crusting which is happening in the center. So it apparently looks like a volcano, which gives you this volcano sign in cutaneous leishmaniasis. This is also called as Delhi boil or oriental sore. So ulcer with elevated rim and central crust. Yes, Shankar, just also do your PYQs, and the content volume is not important, your multiple revisions are important, and the RR sessions which we have kept has been kept in consideration with this, that you have very little time which is left, and then you have to revise it multiple times rather than going here and there. Just focus on the content which is being given to you, because that will be enough for you to solve all your PYQs, and that will be good for exam itself. They don't ask so much of depth from you. Okay. Then your post Kala Azar dermal leishmaniasis, which is your cutaneous sequel secondary to Kala Azar. So when Kala Azar happens, after that, after some time, that cutaneous manifestations can be seen. So in history, you will see patient probably from Bihar because it's prevalent more there. Prolonged fever, history of prolonged fever pointing towards Kala Azar infection will be there. There will be hepatosplenomegaly. So this is all which was happening in past. So when you'll take the good history, you will find it out. Then skin lesions, there'll be two types. One kind of hypopigmented macules which are present, which are on trunk and on face, which will be infiltrated nodules. So I believe that you know what are nodules by now. Then your bacterial infections of skin. Also, you combine it with microbiology. All these infections which we are studying. Pyoderma, your pyo, the word pus kind of. Okay, so this pyoderma can be follicular and it can be non-follicular. So the follicles, when they are involved, it is follicular. So first type is folliculitis, where you can see that this pustules are present, and these are present around the hair follicle. Okay, that is characteristic of folliculitis. Then we have furuncle, where you can see the surrounding erythema which you can appreciate. So that is classical for furuncle. And then you have carbuncle. Look for history of diabetes mellitus, and this is mostly found on the nape of neck. So what is happening in carbuncle is there is an involvement of multiple hair follicles. Okay, then you can see this non-follicular variants, where it can be localized and it can be spreading. The localized one can be impetigo and ecthyma. So, and the spreading one is erysipelas and cellulitis. So when we discuss impetigo, we should know two variants, and let us discuss the non-bullous one, which is also called as impetigo contagiosa. So most of the times images will be given to you. So you can see the golden honey brown honey colored crusting is present. Okay. you can see around the perioral and perinasal area. So that will be the areas which will be involved in them. And what is the causative agents? Staphylococcus aureus and group A streptococcus. So look for honey brown colored crusting in them. So what happens? This vesicles rupture and then they leave this kind of crusting. And in non-follicular variant, we have the bulla which is present. So this bulla, what happens? This when this ruptures, it gives you varnish crust. So this you can see in, again, the causative agent is only Staphylococcus aureus in them, whereas in non-bullous impetigo you can see the Staph aureus and group A streptococcus both. Then we move to erysipelas. Erysipelas, what you have to notice here is it is well demarcated and raised. So this is not at the same level of your normal skin. There is demarcation which you can appreciate, whereas you have to do the differential it with the cellulitis, where it is not. Actually, you can see a little bit of erythema is present around the lesion as well. So in erysipelas, there is a demarcation which you can see, and it is caused by group A streptococcus. Whereas in cellulitis, so it has an ill word here, so it is ill demarcated. Okay, so this spreads, this is diffuse, caused by your group A streptococcus and Staphylococcus aureus. Both are the causative agents for the cellulitis. Also, you can look for in cellulitis, the if you touch the lesion, it will be hot to touch. Okay, and sometimes people can also get fever in cellulitis. Then we move to the staphylococcal scaldedson syndrome, where you can see uh, when you see any question, they might give you history of some ear infection, some eye infection. So there will be a history of some infection. So this, from that source of infection, what happens is your bacteria, that it gets spreads, and it is going to cause this exotoxin is secreted, which is epidermolytic in nature. So this is going to break down your epidermis. So when it targets your skin, where exactly it targets, this is your desmosome, which you have been waiting, your desmoglein 1, and the target antigen is your desmoglein 1. So this actually does what? It makes your cell like this round, and this is acantholysis, which is going to be seen in them, and there will be a subcorneal split. So you can see that this kind of an image will be given to you in question, where you can see sheet like epidermal peeling is happening. There will not be any oral lesions which will be there, because oral, like in mouth, so mouth, with this you can remember, just flip it 3. So this desmoglein 3 is expressed in the oral lesion. So since or staphylococcal scalded skin syndrome, where the Staphylococcus aureus is causing this disease, this is just targeting desmoglein 1, not 3. That is why there are no oral lesions which are present. Mucosa will see toxic epidermal necrolysis. That time we will see that it is going to be involved, your mucosa. Okay, so this just could be given as image-based question to you. This is acute paronychia. So this you can see if you can give antibiotics to this patient caused by Staphylococcus aureus again. And pus filled around the lesion, around the nail bed, you can see. Okay, so this image is enough for you. We can't study everything in rapid revision courses, because we focus more on the things which are asked in exam. And again, I'm telling you that FMG is more related to they don't go in so much of depth for every topic. Then your cutaneous corynebacterial infections, we have erythrasma, which is there. So word erythro is for your red. So what happens? There is a coral red fluorescence which you can see on a wood slab examination, and this is important because has been asked previously. So what is the causative agent? Corynebacterium minutissimum, and you can see this kind of lesion will be there, and the sites which are involved here are axilla and groin. Fine. So what happens? This is asymptomatic, they don't have any itching, but there's just this reddish brown hyperpigmentation which will be present. So the appearance of this is just causing the issues to the patient, otherwise they won't have any itching and all. Then we have trichomycosis axillaris. This is a misnomer. Why? Because it is not caused by mycosis will make you think of fungus, but it is not caused by any fungus. It is rather caused by your Corynebacterium tenuis. And you can see that your hair shaft has some yellow concretions. Okay. So this axillary hairs are involved and they have yellow concretions on them that can make you diagnose your trichomycosis axillaris. Then you have this pitted keratolysis caused by Micrococcus or Chytococcus sedentarius. Punctate depressions, you can see as if someone has, put a pin and made these holes. So this is multiple punctate depressions present on palms and soles, which is classical. Then we move to Pseudomonas. Okay, why this is green in color? Because of the pigment which is produced by Pseudomonas aeruginosa pigment, and this is a green nail syndrome. So the nail looks green under the nail bed. You can see this green discoloration. Then we have meningococcemia. This is caused by Neisseria meningitidis. What you look for is a petechial rash in the patient. And along with this, you look for fever. And again, it is meningitis. Meningitis will be there. So signs of meningitis like neck rigidity, etc. will be there. Then we move to next infectious disorder of skin, your cutaneous anthrax, where Bacillus anthracis, your gram-positive organism, is going to cause this. So in them, what is important is animal products. So the contact with animals. So people who rear all these animals like buffalo or cow, something like this will be given. And there is a central ulcer with black scab. You can see a black scab surrounded by profound edema. You can see around the lesion. You can see here erythema, reddish discoloration, red thing is present. And this is all about cutaneous anthracis. Then we move to scrub typhus. This has been asked, which is the organism which is causing your scrub typhus, Orientia susugumashi. Okay, and what is the vector? It is trabeculid mite, and fever is always there present in them, and CNS symptoms will be there, and there is an eschar. What is eschar? This is black scab which is surrounded by erythema again, but look for history of fever and CNS symptoms. Treatment, you give doxycycline. Next, you move to cutaneous tuberculosis. After a skin infection, we'll probably take a short, small break. Okay, then tuberculosis, verrucous cutis, the anatomist's wart. So this is again happening in the people who handle dead bodies, like anatomists or forensics. That kind of a history can be given. And again, the verrucous mean the cauliflower-like growth is seen. Then your lupus vulgaris. So this, you can see there is indurated lesion. Again, it is having this verrucous rough plaque, and it is present on the extremities. You can see that central clearing is already there in them as well. This is the most common form of cutaneous tuberculosis in adults, where it is present mostly on the face, in the buttocks, or the extremities. You can see here the image which is given is present on the face. So diascopy is used for the diagnosis of lupus vulgaris. So that you take a glass slide and press it. So when you press it, this apple jelly nodules, after pressing, gives your yellow-brown discoloration. So sometimes they can give you the image of diascopy as well, which we'll see later on. And the presence of granulomas is also characteristic for lupus vulgaris, of course, because it is tuberculosis. So you know that granulomas are going to be there. Then we move to scrofilloderma, the most common cutaneous tuberculosis in children. Okay, so this S will remind you of C, child. So in the children, this is present, whereas we saw the lupus vulgaris is present in the adults. So that is something which you have to remember. So this kind of a lesion is there, and this can present as discharging sinus. Okay, and there will be fibrotic scars. Most important for you that it is going to be involved, like cervical lymph nodes are most commonly involved in them. Okay, so next we move to leprosy. I think we should take a break before we start leprosy, because leprosy is really important, as many questions have been asked and it is a little long topic. Okay, so let's take a break. Welcome back, guys, from the break. Let's begin from where we just left. The leprosy, Hansen's disease. So, this is another granulomatous disease after tuberculosis. This is chronic, infectious, of course, and the causative agent is Mycobacterium leprae or lepromatosis. We have different forms of leprosy, starting with indeterminate. Uh, I hope you're all back from the break. So let's continue from the place where we left. So, leprosy or Hansen's disease, again, another kind of granulomatous infection, which we have caused by your Mycobacterium leprae and lepromatosis. Just engage with me, try to revise, okay? So, first form of leprosy, your indeterminate leprosy, is the early stage of Hansen's disease, where the cell mediated immunity is undefined. Okay. So the patient who's going to come in the OPD will be mostly children, where you can see from the endemic areas, you will find it more prominently. There will be ill defined hypopigmented patch, which will be seen. And the differential diagnosis of the same is Pityriasis alba. So Pityriasis word means scaling. Okay. So Pityriasis alba is a different condition, whereas in indeterminate leprosy, you'll not be able to. Am I audible? I hope I'm audible to all. Kindly comment down in the section, please, just to confirm. Okay, thanks, Anirudh. So histologically, you can see perineural and periappendageal lymphocytosis in them. But so there will be hyperpigmented patch which will be there. But in Pityriasis alba, as I was saying, there will be scaling which you can see, whereas in indeterminate leprosy you will not find any scaling. So there will just be ill-defined hyperpigmented patch. Then uh, let us first move to the table and understand all kinds of leprosy first. Then we will come back to this table just to kind of revise it all. So, the Ridley Joplin classification of your leprosy, where the first type is tuberculoid type. Okay, so in this, because the cell mediated immunity is good, so there will be a well defined margin and central clearing in the annular plaque, which you can see. So this is the characteristic skin lesion which is found in tuberculoid type of leprosy, and the lesions will be total 1 to 3 in number. Okay, and so associated features, of course, you'll find granuloma, and good immunity is there. So because of this granuloma, it will be compressing your nerves. So because of that, you will have anesthesia and alopecia, and anhidrosis will be there present in tuberculoid type of leprosy. Then we move to borderline tuberculoid leprosy, where the skin lesions are more in number. So as we move from tuberculoid type to the lepromatous type, what happens is your immunity goes down. So now the number of lesions because of this is going to increase. So this in this you can see somewhere the margins are well defined and somewhere the margins are not well defined. And you can see that there is a satellite lesion which is present also. So this is classical about the borderline tuberculoid type of leprosy. So some lesions are well defined, somewhere it is well defined, and somewhere it is not well defined. Then we move to mid borderline type of leprosy, which is also called as dimorphous. Okay, and there is a geographic map like appearance. So hope you have seen this globe. Okay, that time you can find these patches on the globe. So similar to this, they have compared saying that there is a geographic map like appearance. So there will be total of 10 to 13. So since again I'm repeating because the immunity is going down, so the lesions are increasing in number, and this is having 10 to 30 lesions. All are polymorphic, different appearances there. So there is inner punched out margin, which is present in like Swiss cheese. So you all must have seen Tom and Jerry, and the Jerry used to eat that cheese. So that is your Swiss cheese, which has inner punched out appearance like this. So there is a hole. This is inner punched out appearance, and then the saucer, which is inverted saucer, that kind of margins will be there in your mid borderline type. Then we move to borderline lepromatous leprosy, where the skin lesions and nerve thickening is almost symmetrical in nature. Again, there is inverted saucer appearance of these lesions. And the last, which is important for you is to understand, is your lepromatous leprosy, the last one. So this is the most severe one. Why this is most severe? Because you see it is the last in the category. So the immunity is has gone down a lot, and now you will see this has become the whole systemic disease. Okay, so just answer me what if this is systemic. So there will be skin lesions which will be there, right? There will be nerve thickening which will be there, and internal organs are also involved. Comment down in the section box, comment section, and please keep answering, keep revising with me. So the lesions will be symmetric in nature, and there will be peripheral nerve thickening. So if you see that this is classical leonine faces, which you see, what is that? So he looks like a lion. Why? Because there is thick skin. You can see thickening of the skins is there, and you see this person. There is a loss of eyebrows, so the hair is falling, and this leads to madarosis. Okay, and furrows are there. Thickened skin is there, and in case of neuropathy, it is glove and stocking peripheral neuropathy. So as you can see, the nodules are present. So there is diffuse infiltrative nodules which can be seen. So this is all about the types of leprosy. So now let us move on to the tables, where your tuberculoid type, then we have the lepromatous leprosy type. So your fast bacilli, these are few in number. Why these are few in number? Because your immunity is acting good. Okay, I hope you're all able to understand this. And since in your lepromatous leprosy Hansen's disease, this is more in number. Your fast bacilli, they are more in number, numerous in number, because the immunity is poor, so the bacteria can multiply a lot. Same reason makes your skin lesions going from less in the tuberculoid type to the multiple in the lepromatous type. When we talk about the nerve involvement, here only one nerve is involved, and then multiple in the lepromatous type. Your sensation are lost, classical, and here in lepromatous it is still preserved. Next, we move to the cranial nerve involvement. So this image is also important for you. So cranial number fifth, your trigeminal nerve is involved, which going to decrease your corneal sensation. And with your facial nerve involvement, your cranial nerve number 7, which leads to the orbicularis oculi paralysis. This is going to lead to the condition called as leg ophthalmos. So this picture is showing you that this man is trying to close his eyelid, but he cannot because of the eye involvement. And this leads to exposure keratitis. Both of these condition leads to exposure keratitis. Okay, repeat it with me. So that is going to give you corneal ulcer and corneal opacity. So which all two inverse nerves which we have read right now? Answer in the comment section. The two nerves involved which we just read now. Are you all with me? Okay, and what it leads to? Your exposure keratitis. Okay, ultimately it is going to lead to corneal opacities. Anirudh, it's good, but I want everyone to participate. And can anyone tell me these two nerve thickenings which are seen in the image? What are these images? Which nerves are involved in this? As we discussed, peripheral nerve thickening will be seen. This image has been previously asked around your sternocleidomastoid muscle. This nerve is your thickened greater auricular nerve has been thickened. Okay. Yes. Good. leg of thalamus, there will be there. Exposure keratitis will be there. Greater auricular nerve. So this image, you just see this image. This is actually important for you to diagnose. So around this sternocleidomastoid muscle, your nerve will be seen thickened, and this is your ulnar nerve, which is thickened. That can be asked. So this is PYQ. Next, we move to the other finding, which is trophic ulcers, which can be seen in them. The cause why the trophic ulcers happen because of the peripheral neuropathy, and this peripheral neuropathy is going to cause this loss of sensation. Okay, so because you can't, the patient cannot sense if he's touching some hot objects, he cannot sense that, and if he's walking on a rough surface, so usually you will have pain, so you won't do that. But these patients with leprosy, they'll have loss of sensation, so there will be repeated unnoticed injury which is going to happen in these patients, and that is going to cause the chronic ulcers at the pressure point, so wherever they will be putting pressure. Then how do you manage them? These trophic ulcers are managed by, so you just, the aim is to reduce the pressure on the ulcer areas. So you advise them rest and leg elevation so that the swelling gets reduced and ulceration is not going to happen. Then you actually ask them to use offloading device. What offload? What do you want to offload? The pressure which is occurring, and then the microcellular rubber footwear which is advisable. So what does it do is it distributes the pressure. So that is how it is going to help with the ulcer. So non-weight bearing splints, as we discussed, and this is all about the management of trophic ulcers. Now the diagnosis of Hansen's disease, you need to look for one out of these three cardinal features of Hansen's. So out of this, the skin nerve and the slit skin smear, out of this, one should be at least present to make a diagnosis. So the one is hypopigmented or reddish lesion which should be present. Now, very important, we have seen various hypopigmented disorders, skin condition, but we haven't seen anything with definitive sensory loss. So look for sensory loss because that is not going to be there in other disease condition, but it will be there in Hansen's disease. So that is more important for you to notice. And then we have what? The nerve thickening, which we saw, the enlarged peripheral nerves. Which nerves again? And there will be sensory or motor deficit in supplied area. So these are the two things. And slit skin smear, it will be positive. That is going to help you to diagnose. So either of these three is, if it is present, then you make a diagnosis of Hansen's disease. Then histopathology, you can see this Gren zone, okay, and you can see this lepra cells which are there. Then there is staining, okay, there is a staining technique which is a Fight Faraco stain where the bacilli is seen red colored bacilli. Now, how do you investigate for it? Very important is for investigation for pure neurotic leprosy. Now you know that only the nerve is involved in this kind of leprosy and there is no involvement of skin. So since only nerves are affected, you have to take a nerve biopsy. That becomes investigation of choice in case of pure neurotic leprosy. So choose the sensory nerve. Okay, you can't take any biopsy from your motor nerve, otherwise there will be loss of function in that nerve. So which nerve you can use for biopsy? These are radial cutaneous nerve from the upper limb, you can take that, or sural nerve for biopsy, you can try that. Then you give a maroon kit, and study it along with your PSM as well. This is having multi-drug therapy regime, and you give it for 20. So we give it for 28 days. So every 28 days, the patient comes in OPD for follow-up, and then you give the drug again. Then on the basis of your bacillary and multibacillary type, if the skin lesions are like only 1 to 5, then you define it as bacillary, and when multibacillary, you define it when it is more than or equal to 6. No nerves are involved in bacillary type, and more than one nerve is involved in multibacillary. Then in the multi, because please kindly respond to all the answers which you have been asking in the comment box. I really need your involvement in the class as well. So in the multibacillary type, your smear is going to be positive, and in possibacillary, it will be negative. And duration, if it is possibacillary, then you treat it for 6 months. But if it is multibacillary, you treat it for 12 months. In both of the condition, 3 drugs are given. Which are these 3? Comment down. You also studied in PSM, so just answer me. The rifampicin, yes, you give it for 600 milligram per month. Only day one you have to give it once a month. So government give this red pack for your treatment for in the patients of leprosy. Dapsone you give for day 1 to 28, and as I said that every 28-day patient has to come to OPD and take the drug again. Then clofazimine you give. So these are the 3 drugs you have to remember. And some important side effects of these. Rifampicin, so mostly orangish reddish discoloration of secretion. So I believe that you have probably heard of it, some orange color urine, if it is happening. Which drug is associated with that? Yes, right, Arjun. I can see your answer, R for R. Okay. So orange colored rifampicin anirudh, right? So this is a very famous known question, and it also may induce liver toxicity, right? And then dapsone we have where we have risk of hemolytic anemia in them and agranulocytosis and hypersensitivity syndrome. But most important is rifampicin, which has been previously asked as well. And then clofazimine causes skin hyperpigmentation. I would ask you to at least remember these 2, the highlighted ones for now. And if you can remember more, then it is okay as well. Then, for whom we use chemoprophylaxis, of course, the people who have come in any contact. So, contacts of leprosy patient, if the age group for more than equal to 2 years or adults. Okay, and you can't give this to people with active leprosy infection. You just give to the contacts of the people or of the patient. And then we have to wrap up this leprosy with the Lepra reactions. We have type 1 Lepra reaction, and we have type 2, which is type erythema nodosum leprosum. So type 1, we can see the type 1 has type 4 hypersensitivity type of a reaction. And the lesion which was existing. So we saw that there was a hypopigmented lesion which was present in leprosy. But all of a sudden, what is going to happen? This kind of lesion will be turning red and it will be tender. So once the patient gives his history that he was having a hypopigmented lesion, it was just light in color. That kind of a patient is not going to come and say that it's hypopigmented. So he is probably going to say that it is very light colored lesion was there, and suddenly when he will come, he will say that it is painful, and it is painful and it is red in appearance. So this is the lesion which you will see, and there will be severe neuritis. It will be very painful. Then we move to next is our type 2, which is erythema nodosum leprosum. So this E you turn it that way, so it becomes a 3. So 2 with 2 you can remember erythema nodosum leprosum. So this is a type 3 hypersensitivity reaction, and it is immune complex mediated disease. So again, what is going to happen? This type 2, it will be again a sudden new red and tender nodules will be there. So in this, nodules will be there and fever will be there, will be present. So you can see here they will have nodules. That is classical of type 2 Lepra reaction. Now we discuss the red kit, which will be given to the patient every 28 day. So always continue with multi-drug therapy. So if the patient is coming with your lepra reaction, you will think that probably it is happening because of the treatment, but that's not right. You have to still continue with the multi-drug therapy. That's important. And systemic drug, someone was asking, this is drug of choice, which is one thing, type 1 and type 2, but then again, it is also safe in pregnancy. So in both of the cases, you can give steroid, but specifically for type 2, you can give chloroquine, thalidomide, and clofazimine, higher dose for anti-inflammatory effect. Okay, so that is all you need to know. You don't have to go in so much of depth. For pregnancy, you remember you give only systemic steroids. So if a pregnant female is coming and she's having symptoms of your lepra reaction, type 1 or type 2, doesn't matter. If she had this sudden onset erythema of that, then you just give systemic steroids to that patient. Now, now we move to the most important topic in dermatology, which has been asked so many times that I can't tell you how important it is: the sexually transmitted infection. And in this image you must have seen so many times in your exam. This image you might have seen so many times. So, what is this? Your anogenital warts, which are there. So, the anogenital warts, your condyloma acuminata. So this acuminata is for pointed lesions. Okay, so you can see the lesions are pointed like this, and then there is later on it becomes cauliflower-like lesions. Okay, so this is condyloma acuminata. Has been asked, so you have to keep this in mind. Causative agents is HPV-11 in the most of the cases, and this is in 90% of the patients, this will be caused by this, and then 16 and 18 in the 10% of the cases. So these kind of lesions will be there, and coilocytes is classical for them. So you read it, you also read this in microbiology. Then we move to urethritis. We can see profuse and purulent discharge in urethritis, gonococcal urethritis particularly. So this is seed kind of a discharge, okay, and this is profuse, thick, purulent discharge, and the incubation period is 2 to 5 days. And what is the causative agent? This is gram-negative intracellular diplococci, which can be seen in histopathology. That can be seen there. Then you have to study it all together. Like there should be a differential between the two conditions, your non-gonococcal urethritis. So where in the gonococcal one, you have a profuse and purulent discharge. On the other hand, in case of non-gonococcal, you have a scanty and mucoid discharge. So that is one thing you have to remember. And in the non-gonococcal one, the incubation period is longer. It is 7 to 14 days. Okay, what you can see on the histopathological examination is numerous polymorph nuclear cells, and this is more present intracellularly. And the causative agent, you remember causative agent more, that could be asked from you, Neisseria gonorrhea. And this you have to remember in case of non-gonococcal urethritis, obviously it will not be Neisseria gonorrhea. It will be Chlamydia trachomatis D to K variant. That is most common for this condition. And another microbes which are implicated are Ureaplasma urealyticum, Mycoplasma genitalium, and Trichomonas vaginalis. Here it is also implicated. Then the treatment will be ceftriaxone you give for the gonococcal one. So you can remember with this G, you can make a C. So ceftriaxone you can give in them stat dose of 500 mg IM injection. And you can also give doxycycline for 7 days BD. That means twice daily. Then, in case of non-gonococcal variant, you can give tab azithromycin 1 gram, and doxycycline you can also give in them as well. Next, very important, again, has been asked previously. Now, all those who are discussing Candida albicans in comment section have a, you should look into the presentation right now and answer accordingly. Candidiasis, the vaginal thrush. So, what happens in them? We use for to distinguish various candidal infection. We can use chrome agar in candidiasis patient. So when the patient is going to come, the female is going to come, let's say, and if you ask for further history, she might tell you that she's a diabetic female and she probably takes SGLT2 inhibitors. So look for these SGLT2 inhibitors and diabetes history. That will help you to make the diagnosis of candidiasis. And this is a very itchy condition. They will have a lot of vaginal itching, and of course, everyone is knowing this. There's a very common fact that curdy white discharge is seen in candidiasis. Now you can discuss as much as you want about this candida infection, Candida albicans, Jyoti, and everyone who have been discussing about it. Then we have trichomoniasis, which is caused by Trichomonas vaginalis. So the type of discharge, to understand this type of discharge, is very important here. And this is a flagellate organism. You can see this flagella, and the discharge here is greenish yellow and frothy in nature, and this is a classical finding which is seen in Trichomonas vaginalis. Can anyone tell me what is it? What is it called as, the classical appearance of the vagina, of the cervix? Strawberry cervix, yeah. So that's what you can see. And in bacterial vaginosis, what is happening is there is imbalanced vaginal microbiome. So what is the normal vaginal microflora? What is there present normally? What it should be? Yes, Anirudh, Prem Kishore, Arjun. I'm happy that all of you are participating. But let's whiff test is positive, that is fine. That's also written, but I'm asking the normal vaginal microflora. What is it? I'm not asking pH, Jyoti. Are you done with microbiology already or not yet? So the bacterial vaginosis, there is an imbalance which is happening. The altered microflora. Why it is altering? What is getting decreased? The Gardnerella species, Mobiluncus and Lactobacillus. What is happening? Lactobacillus is actually decreasing, and because of that, Gardnerella and Mobiluncus and others are increasing. That is what is happening here. So in them, there will not be white curded discharge. It is homogeneous white, and this discharge is adherent to vaginal wall. That is classical for them. Then you get, so take keywords, okay? Because before exam time, you should focus more on the keywords in any disease condition. So whiff test, as everyone is well aware of in bacterial vaginosis, it is whiff test which is positive, or it is also called as amine test. Now, how do we do this test? We take the vaginal discharge, we mix it with KOH, and what happens is there is fishy odor, fish-like smell which is coming. So that is your whiff test. And from your vaginal wall, we can take this squamous epithelial cells can be seen. And on this, the bacteria is adherent. So that is called as clue cells. And if this is more than 20%, that makes the diagnosis of bacterial vaginosis. Very important for them, we use a Nugent score for bacterial vaginosis. You don't have to know the details of it for your syllabus. Then we move to syphilis. Are you all with me? Are you enjoying the session? Let's see, Jarvi. I believe it's going to last for another 1.5 hours at least. Okay, syphilis. This is caused by Treponema pallidum. But if you participate and if you keep answering, it will not be boring at least. So we can have congenital syphilis and we can have acquired syphilis. This is a revision session. So as much as you people participate, that will be more appreciated because that's what going to help you as well. So the early uh, congenital syphilis will be there in patients or the babies which are less than 2 years of age. And the type of lesions which are present are vesiculobullous lesions, as you can see. And in the late syphilis, which is present in the patients who are more than 2 years of age, the classical finding is this Hutchinson's teeth. Okay, so the incisors are seen like this, which is called as Hutchinson's teeth. So what happens in Hutchinson's triad is one is the Hutchinson's teeth, which look like this as in the image, and then there is interstitial keratitis and sensory neural hearing loss, which is there. The yes, the notched teeth appearance, hearing loss is there in the patient. So you have to remember Hutchinson's triad for congenital, the late syphilis. And when we move to acquired syphilis, it can be of primary and the late types. In case of primary, we can see the lesions again are vesiculobullous type. And there is a chancre which is present. What type of chancre it is in syphilis? Can anyone tell me? Yes, I really need your involvement here. Condyloma lata is this one. Okay, so this is flat surface, which is there in the late variant. Painful. It's a hard chancre, okay, and there is generalized lymphadenopathy, which you will be seeing in them. Condyloma lata is this one. We also read one more thing, Condyloma acuminata. Why acuminata? Because it was that prominent thing. But this is lata. Lata is like leta hua. Okay, that means it's flat topped. So that is Condyloma lata. And in them, so late uh, secondary. This is secondary. Okay, the secondary one. And in the secondary, what is going to happen? You remember S. With this S, you can remember on the scalp, something is there. What is this? The moth-eaten alopecia, as if the moth has eaten parts of the hair, and it is going to give you this moth-eaten alopecia kind of a finding. So this S is going to remind you of scalp, and that's how you can remember it. Then you can have polymorphic rash, which is there, and this polymorphic rash will be seen in them. Then about investigation of choice, which is there. VDRL can be done in these patients, and RPR. Can anyone tell me the full form of VDRL, please? Truck driver, chocolate agar, pus painful. I don't know what is all happening among you all. What are you discussing? What is the full form of VDRL? Yes, are you guys with me? Am I audible? Chocolate venereal disease research laboratory. Good try. Yes, yes, yes. And RPR, anyone? What is for RPR? For your knowledge, I'm asking, and for your involvement so that you just wake up. Rapid plasma reagent. Okay. But if it is a neurosyphilis case, the investigation of choice becomes a CSF VDRL. So you again do a VDRL, but with the CSF. The fluid is changed. That is CSF. So now treatment. Let's discuss the treatment. For the early syphilis, you give early and latent injection benzathine penicillin. 2.4 million units deep IM. Probably you won't be asked the treatment, but just you can lata tata. What is it? Moses. So I don't know what kind of mnemonic you're making. Then in late syphilis, you can use injection benzathine penicillin again. You give it for one injection per week and you repeat it for single dose. While for early syphilis, you just give a single dose. No need to repeat it for the next week. Neurosyphilis, you have to see that it is aqueous crystalline penicillin, which is given for 10 to 14 days. I hope you'll all be able to crack the question of syphilis if it comes. What kind of chancre it was in syphilis? Because now we are going to see the soft chancre. Then we also have to know what is the chancre of syphilis. You just have to have some basic idea about the treatment. Hard is yes for syphilis. Good. And then next we move on to the other types of sexually transmitted diseases. The first being the chancroid, in which the causative agent is your Haemophilus ducreyi. So ducreyi is cry. So why someone is crying? Very famous. Is it going to be painful? The chancroid. Yes, absolutely, Ansari. And it is a soft chancre. So, this chancroid's C is going to remind you of soft chancre. Okay. On the other hand, please understand this that syphilis is going to be presented with hard chancre. Then okay, if you, what is a bubo? Can anyone tell me before I tell you that? Yes, Prem Kishore, you're absolutely right. Yes, the painful lymph node, yes, ulcer. And this will be characterized with a unilateral bubo. So remember C chancroid sounding similar, soft chancre and single bubo, unilateral single bubo. School of fish or rail track appearance will be seen. So please involve yourself, okay? Because unilateral bubo, which is present with the enlarged lymph node. That is how chancroid is going to be present. So these all come together when a question is given and when clinical based scenario is given, they'll give you all these in your option. So that is why it is very important for you to understand and how do you gonna do the differential diagnosis of these conditions. So one thing is this soft chancre is present and there will be multiple lesions which are present. That is also classical about chancroid. Then you move to herpes genitalis. HSV2 is implicated in most of the organisms, the 90% of the people, and then only in the 10% of the people, HSV1 is implicated. So for herpes, we also have seen the orolabial variant. Remember? Can anyone tell me orolabial is caused by which herpes simplex? And what kind of characteristic lesion is there in herpes simplex? Yes, all the active participants, Anirudh and Jyoti, Prem Kishore. We did orolabial herpes, the cold sores, right? We did that in our viral infections. Below belt, above belt, absolutely right. Above belt is 1, below belt is 2, and this is our below belt condition. HSV1 upper half. So what was orolabial herpes? HSV1 was implicated there, and what kind of lesion is there? I told you that very specific thing about it. I understood HSV. Now let's come to the lesion type of lesion. What is the classical finding there? Still waiting for your responses. Okay. Check yourself. Then the vesicles are present, and these vesicles are grouped. Okay, so there is one particular place there where they are present in group. This is present in group. This is very classical of your herpes. Okay, and they're painful as well. That's what I was asking. So here also vesicles are present. If you remember fluid fills, of course, vesicle is a fluid fill lesion only. And what happens is when you put a torch on the patient, it is appearing shiny as well. They have polycyclic margins, the lesions. What you have to remember is Tzanck smear is taken for them, where you can see multinucleated giant cell. Lymph node are tender and bilaterally enlarged in them. So how you gonna remember this? Genitalis to T is going to remind you of 2, HSV2, and then again bilateral, both sided lymph nodes are being tender and large. So you have to do a comparative study of these STDs. That is how you're gonna crack the question in the exam. Then let us come to the lymphogranuloma venerum. This is caused by chlamydia trachomatis L1, L2, L3 serovar. Whereas we just read a condition whereas chlamydia trachomatis D2K variants were involved. What was that condition? Anyone? Let me check if you're even listening to the class. Yes, Moses, if you remember, then let me just tell me which condition was that. For lymphogranuloma venerum chlamydia trachomatis L1, L2, L3. And since there is an L, you can remember this is L1, L2, and L3 serovar, whereas D2K is for, I'm giving you some time, I'll wait for your responses. Then the 3 stages which are present. The primary, in this you have a single painless transient ulcer. So it comes and goes. Okay, then there is a secondary lesion, secondary LGV infection, where you can see a bubo and a non-concomitant genital ulcer. In the third one, there is tertiary variant, there is genital elephantiasis. Correct the spelling. Elephantiasis will be seen. Okay. So the microbe is further invading, leading to genital elephantiasis in them. Then in the end, you have to also study the donovanosis and granuloma inguinale. Okay, so remember, this is caused by Klebsiella granulomatis. Moses wants to have a dinner break. You can eat while you're studying, probably, right? So there is a single painless ulcer which is present. Okay, single painless ulcer, and it is beefy red. So probably you might have seen beef. So it appears like a beef red, and it is painless. So donovanosis. So you can remember no. Okay, and no. So there is no pain in this condition. So this is single again, and it bleeds on touch. And there is Pund cells, which you will study in your microbiology again, and inguinal lymph node is normal. Okay, but there is subcutaneous nodule which is present. So apparently this is going to make you feel as if there is swelling of lymph node, but it is actually not a lymph node swelling. There are just nodules which are present. That is what it makes a pseudobubo. Okay. So treatment you give azithromycin, 1 gram stat for your chancroid. So air conditioner AC chancroid, you give azithromycin stat. Acyclovir, I believe for herpes, all of you know that acyclovir is the treatment of choice. Yeah, safety in appearance is correct, but that is more appropriately you can read it in microbiology, right? We can't study all subjects. Then we have doxycycline for your lymphogranuloma venerum. Okay, so remember this LGV has chlamydia trachomatis, and doxycycline is to be given for 3 weeks. You don't have to remember the duration, just have some basic idea about the treatment. Then azithromycin again for your donovanosis. Okay. All good. I hope that this is something which is going to. Yes, I believe that these tricks are very great when you are having a less time for your exam to go, because you will realize it when you sit in the exam that those alphabets are coming to your mind. So donovanosis, when you see do no, so no pain is going to be there. Okay, I'm just repeating it because it is one of the important topics. And do cry is going to actually, this cry mnemonic is for everyone knows already. So cry because it is painful, multiple lesions are present. So with the CS thing, you remember the whole condition, and there will be unilateral bubo which is present in them. Then herpes genitalis, T reminds you of 2. So below the belt, as everyone has been telling in the comment section. So HSV2 is implicated in most of the people. Vesicles is very classical for herpes infection. So we don't have to even think of, even if it is genitalis variant or orolabel, herpes will, vesicles will be there. And herpes is always, tender, painful. So painful it is. So tender lymph nodes will be there, bilaterally enlarged, because you see that T was the something which we started with. So 2, and that's how you're going to remember this. And LGV, you remember the, with this G, you remember a C, you can make a, out of a G, you can make a C. So chlamydia trachomatis, L1, L2, and L3. And then this is primary stage, you can have a single painless transient ulcer, and in secondary you have bubo, okay, which is not concomitant with the genital ulcer, and tertiary you have C. So 3, you can just do it like this, and elephantiasis will be in the tertiary. All good. And then the beefy red is for donovanosis. So beef, you can have it for dinner, donovanosis. Okay, and in donovanosis, VAN. So donovanosis, it sounds like 1. So there will be single painless ulcer. No is going to make you remind that it is just there is no pain, and 1 van is going to remind you of 1. That means 1 ulcer. Merry Christmas. It's still there's let's study. Prem Kishore, I believe Christmas. You can celebrate Christmas after your exam, right? Okay, then how do you let us make it more easier? So if you want to study a day before exam, now you can't remember everything, but there will be history given in the question which you will be solving. So syphilis, so lis is for less, okay, so it is painless genital ulcer, and the lymph node is also less painless. So both of these are painless. Then you have a chancroid. Okay, cry. You just cry because you have a painful ulcer and a painful bubo, which can be there, cannot be there. So at least in chancroid, you have to remember it is painful. So if it is coming painless, no worries. You can think of either syphilis or donovanosis. or LGV. Okay, but then genital herpes, very classically, you'll be able to distinguish. So if painful is coming, then you have to just make a differential between either chancroid or genital herpes, right? So chancroid is also painful and genital herpes is also painful. But in genital herpes, the bubo is not painful. So that is what there. Okay. Then we have LGV. So this is also painless. Okay. And painful bubo can be present, cannot be there. And as I said, van is for one. So there is single painless ulcer, which is there, beefy red in appearance. Okay. No lymph node is involved in this. So this table can make this easy for you. And then all of us knows that this is one of the important topics, the syndromic management of STDs. This is an overlapping topic. How long session will go? Probably another 1.5 hours, I guess. So we took a break. That's why it apparently feels a long session. But I believe that you all are enjoying the session, right? Not half an hour. At least it will last for more than 1 hour. Uh, that's what I told now, Pranjal. You have to revise it one more time at least, because all the tricks which I have been giving you, that you can only remember once you are revising it. Okay, like in donovanosis, one, when we say donovanosis, it sounds like a one, right? So there is one single ulcer. That's how you can remember it. If you're listening to my session right now, these are the most confusing things. If I'm going to give you mnemonics for everything, then it is going to be very difficult to remember the mnemonics itself. So the tricks will be only given there wherever it is necessary and needed. Otherwise, it's going to be very difficult for you to remember the mnemonics itself. Okay. So these kits, the gray kit is kit number 1. And what does it have? It is to be given in urethritis or cervicitis cases. And this has cefixime, azithromycin. Okay, the stat doses of everything. What is the target disease? It is gonococci and chlamydia. Now, the trick to remember is that it is a G, and with a G, you can remember gonococci, and you can make a C out of a G, you remember chlamydia. Good enough? Then we have, but uh, don't get confused it with your green, okay? Because green is coming at second position. This is the kit number 2, and it has 2 E's in it. So this is another one. So you can don't confuse it with gray kit. The green kit is 2 because it has 2 E's in it. So you give it with for a vaginal discharge. So you give it for bacterial vaginosis and trichomoniasis and candidiasis, all kinds of vaginal discharges. Okay. So it has secnidazole and fluconazole in it. Then we have third one. So with a 3, you can make a W. Okay. So if you flip your 3 like this, so you can make a W. Now, all those people who wants a trick, please focus right now. So a 3 can be flipped to make a W, and this is used for non-herpetic genital ulcer disease. So where can you use it? The hard chancre disease, syphilis, and your chancroid as well. Are you with me? So C, how you gonna remember C? C is the third alphabet. Okay, it is the third alphabet. Now listen to the mnemonics as well. And then you have a syphilis. So sir sounds like this, C, C3. That's how you can remember. So it has benzathine penicillin in it and azithromycin in it. So these kits are to be given in resource limited settings. in a PHC where you don't have a specialist sitting in OPDs. So that time you can give them. Are you with me? Moses, what is this joke of yours which you keep saying again and again? So fourth kit is blue. Okay, so 1, 2, 3, 4. There are 4 letters here. It is a blue kit, and where you can give again in syphilis and chancroid you can give, and it has a doxycycline and azithromycin in it. Then we have a red kit, which is the fifth one, and this sixth one is a yellow. So you probably might have heard this ad, dirty fellow. Okay, yellow, yellow, dirty fellow. So when there is something very dirty, we say this chi chi. Okay, so chi will remind you of six. Okay, so six one is the yellow kit, and this is for gonococci and chlamydia. The patient is going to come with a lower abdominal pain. In this condition, you give a yellow kit to the patient. Then last, the black is the inguinal bubo. You give it for inguinal bubo, which is seen in chancroid and LGV, and it is having azithromycin and doxycycline. This is the last one, the black seventh one. Okay. Then we move to the pigmentary disorder. I hope everyone is doing great as of now. So let us try to wrap up the. Can I have a Can I increase the speed of the session? Okay, then hyperpigmentary disorders. So there will be a lot of pigmentation which is there. Melasma is one condition which is there, where you can see females most of the times will be coming to the OPDs, showing that there must be some history that there will be hyperpigmentation over the sun exposed areas, maybe your malar areas and your nose. Over here, the pigmentation will be there because of the melanin production. Okay, so there will be association to this. Either it will be because of the sunlight, so you give a sunscreen to the patients, and there will be a thyroid dysfunction which will be happening in the patient. They might have a thyroid disorder, so you always rule out the thyroid disorder by taking history, or you can just order a thyroid function test as well. Then if a female is pregnant and if she's coming with this hyperpigmentation over the malar surfaces and the nose, then you call it as mask of pregnancy, which is called as cloasma. So this is the same condition, but it is just giving a different name during pregnancy, the cloasma. I hope you can remember this. Then we have freckles and lentigines, which are present. So these are dotted appearance. So if you might have seen so many foreign people with these freckles, which are very common in them. And these freckles, if you can see, the melanocytes are normal in number, but their activity goes increased. So most of the time, these kind of questions are asked with image-based things. And these freckles are also associated with a very important disorder, which is xeroderma pigmentosa. And this xeroderma pigmentosa, what happens in this is the patient will have some UV exposure, the sunlight exposure, and sun sensitivity will be given in the history. So the mother probably might say that whenever the children goes and under the sun, in the sun exposure, he has this typical kind of appearance of freckles, and it can go worse as well. Then we have this Peutz-Jeghers syndrome is also there when the mucosa is involved, and these lentigines are present on the mucosa as well. Okay, so what happens in them is the activity of melanocyte is normal. On the other hand, when we were talking about the freckles, the melanocytic activity was increased. This one is associated with Peutz-Jeghers syndrome, and this has been asked, the congenital melanocytic nevus. So you focus more on this image because this has been previously asked as well. This is benign melanocytic proliferation. This has well defined margins. So this will have a well defined margins, and it will be hypertrichotic and hyperpigmented. So more melanin production is there. There will be a lot of hair on that particular area within that well defined margins or borders. So there is a risk of melanoma in the patient. When the size of this congenital melanocytic nevus, if it becomes more than 20 centimeter, then the patient has a 2 to 5% risk of melanoma. So anyone coming with this congenital melanocytic nevus, then you have to figure out if it is not more than 20 centimeter in size. Okay, that is what you have to remember. Apart from this, you just see that the patient who's coming with this will be having some hair strands over the lesion, and if that is there, then in that case also the children is going to present with this condition. On the other hand, Becker's nevus, so you can confuse congenital melanocytic nevus with your Becker's nevus. Okay, these are the two conditions which you can get confused. In this, what is happening is this is also hypertrichotic. So here is gonna be seen here as well, and it is also hyperpigmented, as you can see. So this condition is also hypertrichotic, hyperpigmented, but most of the time this is going to be present in adults because this is not congenital. This is acquired. But on the other hand, your congenital melanocytic nevus, this will be also hypertrichotic, hyperpigmented, but this will be presented in children. Becker's nevus is probably not well defined. It is more present on the shoulders, and it is unilateral. It is not going to cross the midline as well. So it is acquired, as I said. It is unilateral, hyperpigmented, hypertrichotic. Both of them are hypertrichotic, but this is present in the adulthood mostly. And the lesion which will be presented is on the upper shoulder and chest. So remember, these images have been asked. They are not going to ask you the whole details of it, but you should be able to make a spot diagnosis of the conditions which I have shown here in your pigmentation disorders. Okay. Then we move to dermal melanocytosis. So this one is your Mongolian spot on the baby's back. This is the site, and they have chosen these images only. So then we have a nevus of Ota, which is, O will remind you of ophthal. Ophthal will remind you around the eyes, and also there is a trigeminal nerve involvement. And the Ito variant is present over here. So you should be able to diagnose. So these are more grayish, gray to bluish, slate-like appearance will be there of the lesions. Mongolian spot, as you can see, is present in infants and lower back. And both of these, the Ito and Ota, will be unilateral. And this is present on the your around the V1 and V2 of the trigeminal nerve. These are like Mongolian spot is self-limiting. Okay. This is all you have to know about. Moses, you can have your dinner with the class ongoing. Nobody is seeing you. Then shoulder and scapular region, that was the place for your Ito. And for Ota, you remember with Ota, you remember ophthal. So it is going to be presented around your eyes. Okay. That's, again, I'm telling you, most of the times, these kind of images are going to come straight as spot diagnosis. So you are having a good chance to just crack this with only images. Next, we move to the hypopigmentary disorder or the depigmentary disorder. So first, which we have is your albinism. Important. See, only going to tell you the most important points that this is going to happen in because of the defect in tyrosinase enzyme deficiency. So this occurs in association with Chediak-Higashi syndrome. You might have read it in pathology as well. So in Chiari-Higashi syndrome, list gene goes defective. Okay, that is going to be the condition associated with albinism. You can see the albinic baby here, and the pie baldism. So you must have eaten a pie. Okay, so the pie is more like triangular thing. It's like a pastry only. Fine. So there's a white forelock affair which is seen in pie baldism, and it is a neural crust defect and autosomal dominant in nature. Again, this has been asked in just like this white forelock image based question itself. Okay, so there is a triangular depigmented area with the white hair that is present in the pibaldism. In nevus depigmentosus, what is happening? This is a melanosome dysfunction which is happening. All of if you remember, the first thing which we read today was melanocytes and melanosomes, which is going to produce melanin. Anyone who can tell who from where melanin is going to get synthesized? A biochemistry question. Think and answer me later on. Then the hypopigmented lesion with feathery margin. So you can see that this is not well defined. This is as if, it's like this feathery margins is there. Yeah, melanocytes are present in stratum basale. That is right. Then we have a condition called nevus anemicus. Now, this anemicus is going to remind you of anemia, but it is not going to do with the direct anemia condition. What it is going to tell you is that there is a vasoconstriction which is happening. Now, because of this vasoconstriction, the particular region is not going to have a good supply, okay, of blood, which is going to give you the congenital white, it is also congenital, a white patch which you can see. So this anemicus should remind you of something to do with blood and from where the blood comes. So this is happening because of the vasoconstriction. So I hope that Tyrosin, absolutely right, Mr. Techie. I'm happy with your answer. Then we have vitiligo. Okay. So anyone, vitiligo is depigmented or is it hypopigmented? Anyone who can tell me? A few basics which you should already be knowing. Anirudh is saying hypo. Prem Kishore is saying depigmented. Raja is saying hypopigmented. So for all of your confirmation, I'll tell you. Okay, just compare. Just compare vitiligo image which is shown to you with nevus depigmentosus for an example. Which looks more whiter? Is it vitiligo or is it nevus depigmentosus? Jyoti is also saying hypopigmentation. Vitiligo appears more white. So again, think about it. It should be like absolute absence of that pigmentation, or it is just again, I'll give you a hint. It is autosome, like autoimmune disorder. So the cells are being destroyed. So there is no pigmentation, as Mr. Techie said. So it will be a depigmentation lesion, right? So there is a depigmentation. That is very, very classical for vitiligo. Vitiligo is seen often in OPDs. You can see absolute absence is there. It is not hypopigmentation. Remember, vitiligo is depigmentation because melanocytes are absent in the lesion. It is autoimmune. And on the other hand, there is another condition which is chemical leukoderma, which is also going to give you hypopigmentation kind of a picture. Okay. So, what are the triggers for this? Even the name is saying, okay, chemical. So, it is induced by a chemical. Then we have a leuco. Leuco word is for white, and derma is for your skin. So, there is some whitening of skin which is happening because of what? When the dermatitis has been asked, they ask you the chemical, the trigger of it. So, this is something which is induced by the chemical, like chemical leukoderma. If we see the bindi dermatitis, which is commonly called in India, and I've seen that in OPD as well. So it is para-tertiary butyl phenol. So remember, don't forget the name of this chemical as well. They have asked this, okay? And then we have a rubber. Sometimes people wear a bad quality rubber footwear, which gives this kind of an appearance. So this is monobenzyl ether of hydroquinone, which is going to be the rubber footwear. Okay. Are we good to go? Move ahead. Vitiligo has to be discussed in a little more detail. We have a segmental and non-segmental and unclassified vitiligo. Okay, so segmental, the name itself is telling you it is present in a particular segment like this. Early childhood is the time where it appears. So segment C sounds like a C. Okay, so childhood is the time where it is going to appear. And there will be plus minus leukotrichia. What is leukotrichia, guys? Can anyone tell me? Break the word and tell. White hair, yes. So there can be a condition, or like in segmental vitiligo there can be white hair also, there cannot be a white hair as well. Then we have a acrofacial variant of non-segmental vitiligo, which is, what is the meaning of acro and facial? Now you can teach me this because this is simple English. Acro word means it's not absence for sure, Moses. Acrofacial. So the word acro is for the extremities, like it is the patient is are going to present, maybe the hands, like the fingers are involved, okay, and the face, the parts of the face is involved, the foot might be involved. So you can even see in the image, if you can't use your acronym thing, scalp probably is involved. So all these are like the extreme parts of the body. Okay, then, but acrofacial face is also involved, extremities. And whereas in the acral, most of this, the hands are involved. Okay. And then there is this most common variant of vitiligo, which is vitiligo vulgaris. What is special about vulgaris? If you can see in the image, this is, I hope you can appreciate, this is depigmented, this is depigmented, this is depigmented, this is depigmented, and this and this. So what is it? It is bilateral symmetrical distribution. Okay, so this happens in your vitiligo vulgaris being the most common one. Then we have a universal variant where you can see more than 90% of the body is going undergoing depigmentation. Only this small patch of pigment is just still left. Then there is this unclassified where we have focal. So there is a focal loss, like somewhere all of a sudden with no particular distribution. Some foci of depigmentation will be there. So that is a focal vitiligo, and this image has been asked of unclassified as well. Okay, so clinical features, as you can see, this basically, as I said, it is depigmented entirely. Very important, you have a true Cobbener's phenomenon in vitiligo. Any other places where you see true Cobbener's? Can you just repeat? Chalky white depigmented macules can be seen. If you can see, this is some part which is going depigmented, and the hair which are present there are also going white, because, and this is called as leukotrichia. So what is Cobbener's phenomenon? Anyone? I have just told you as well. Cobbener's phenomenon. From where did the scabies come, Jyoti? Just generally, I'm asking. Cobbener's we read. I just explained you pseudo Cobbener's. Where did we see pseudo Cobbener's phenomenon? Yes, Pranjal, you're right. But where did we see pseudo Cobbener's? Molluscum is the right answer. And can you also lesion due to trauma? Absolutely right. So if you cause trauma, like if you scratch or if you just some due to some any other reason, if trauma is happening and the lesion are coming to the site of trauma, then this kind of a sign is called as Cobner's phenomenon. So a true Cobner's is seen in vitiligo, very important to note. And what do you give for treatment? You give steroids, systemic therapy as a thioprine you give, and then you can use also topical steroids, which tacrolimus also you can give. And if it is a very severe variant, let's say if it is a the whole body is affected, then you give also narrow band UVB, which is of 311 nanometer of wavelength, plus minus 2. Okay. Then can we move ahead with papillosquamous disorder? Then we have to discuss very important condition, which is your psoriasis. Anyone which word psoriasis can make you remember SOR, one particular surface which is involved for psoriasis? Is it extensor surfaces of the body or is the flexor surfaces? Yes. Extensor, prandial, absolutely. So this sore, extensor will remind you of extensor. Exactly, Ritik. Pathophysiology, what is there? So just remember it like psoriasis, sort. You remember it like sort. So T cell mediated inflammatory disease it is. Extensor surfaces are involved and it is early onset psoriasis. Fine. In early onset psoriasis, which is involved HLA-CW6. So this is very classic of psoriasis. You might have not heard of HLA-CW6. And whenever it is psoriatic spondylitis, so S is going to remind you of 7. So HLA-B27 is involved here. Fine. What is happening? I told you something about this transit time. What transit time it is? 3 to 5 days. Something is decreased. Anyone who can tell? We just discussed it in the beginning of our lecture. Flexor in Lichen Planus, absolutely right. Anyone which is decreased? Epidermal transit time. What is epidermal transit time? Yes, fine. And what is it? Can anyone explain? The differentiation of cells from basal to corneum, right? That's what we discussed. So normally it is how many days? 28 days. And here we have just 3 to 5 days. So that is significantly decreased. Fine. So the inflammation which is happening in them, it is mediated via TNF alpha, interleukin 17. Remember this, and interleukin 23. Okay, then we move to the various variants of psoriasis. One which we have is psoriasis vulgaris. Okay, vulgaris means all those who have been telling about scaling until now, that now the time has come. It is not general. Vulgaris means most common. Okay, so this is the most common variant which is seen, and you can see the lesions are red, scaly lesions, and silvery white scales are present. So, if the patient of psoriasis vulgaris comes and you scrape off the lesion with a glass slide, what you get is silvery white scales on scratching with that glass slide. And later on, what happens? Uh, you just scratched and you got a membrane, and then you get these hemorrhagic points. Okay, this is what is called as Auspitz sign, which is present in this condition, which is psoriasis vulgaris. Okay, so this is something which you have to remember, and all your extensor surfaces are involved. That is something which you have to remember. Auspitz sign is positive in psoriasis vulgaris, and Cobner's phenomenon is also there. Where else we just read Cobner's? Pranjal, yes. We just read commoners. Where was it? Pinpoint bleeding is there. Yes, this is the ospit sign. So when does it happen? When you scratch the lesion with the glass slide. This is the vitiligo, absolutely. So now we have two conditions already where Cobner's is there, positive. Okay, so you have to look for these signs because they are going to help you make the diagnosis. The guttate psoriasis, word gutta means the raindrop. Okay, so this is raindrop kind of a lesion which is seen in them. They are present in the childhood, and this happens in group A beta hemolyticus streptococcus is the causative agent. Okay, so what happens, this causes this pharyngitis and this follows this guttate psoriasis. So when you take history, you will be able to know that the baby or the children was having a fever, he was having pharyngitis, and then after some days this is going to happen. Yes, Moses, 28 days is the normal epidermal transit time. Then you have a pustular psoriasis. Okay, so pustular psoriasis, whenever the word pustule comes, so there will be some yellow thing which is coming pus like. Okay, so sudden pustules are there. So when it is pus, you will always also can see fever. This is triggered by steroid withdrawal. What happens that probably if the patient was taking steroid and then when it was withdrawn, suddenly the patient is going to come with these sudden pustules with or without fever. Now what happens is these pustules, they are like this individual signs and then they coalesce to make a bigger lesion, and this is called as lakes of pus appearance. So that is very classical of your pustular psoriasis. And there are two types of pustular psoriasis: von Zumbusch type, which is acute and generalized, and very important, impetigo herpetiformis. Okay, this is pustular psoriasis of pregnancy. So in pregnant female, you will be able to see this. Okay. Then you have erythroderma. Then erythro word itself means the red. So the erythema must be there, scaling will be there, and this is a very severe form of psoriasis. So lot of erythema, lot of scaling will be seen in them. And in the end, you have a psoriatic arthritis, which has been asked previously. So this is also a PYQ. So this is the seronegative form of arthritis. If you try to figure out, like if you check for rheumatoid factor, that will be negative. That is why we call it as a seronegative arthritis. And classically, if you see, distal interphalangeal joints are involved. Okay, so that is all is enough for your psoriasis. And then, as I told you, that Cobner's phenomenon is something which we have already discussed a couple of times. Now, let us, as we discussed, new lesions occur at the site of trauma if trauma is being done, and it can be of true type, true Cobner's, and it can be of pseudo. Pseudo is occurring because of the auto inoculation which happens in molluscum contagiosum, which we saw already, and viral warts. Okay, and true happens because of the immunological condition. We already discussed vitiligo and psoriasis, both of which had true Cobner's phenomenon. Okay, I hope you're able to understand and remember everything. And then we have Lichen Planus, which we have to discuss. Then these are very, very important. The nail findings, okay? When we talk about psoriasis, we have to actually read the nail findings as well. This, if you magnify it, there will be some pittings in the nail, deep pitting, which is irregular, which can be seen. Then there is subungual. So this, you can see the hyperkeratosis, which is present under the nail plate. Okay, subungual hyperkeratosis, which can be seen, and there is onycholysis. So if you can see, part of this nail is lysed, is broken. So this is onycholysis. And then this kind of as if some oil has been there. So this is oil drop or salmon patch sign. So you remember it with the, only the images. I hope you're able to understand everything. Please, please make sure that you remember all the nail changes. That can be given in the question as an image based thing. Then in histopathology, if you see uh, hyperkeratosis, okay, thickening of stratum corneum. You remember I told you in the beginning that stratum corneum is the keratinized layer, okay? So that can help you with hyperkeratosis. If there is a lot of keratinization, thickened stratum corneum is happening, that is going to give you this thick stratum corneum. Then we have parakeratosis, where the stratum corneum, does it have nuclei? The cells in the stratum corneum, they don't have nucleus, right? Normally. But if the nuclei persist in the cells of the stratum corneum, then we call it as parakeratosis, right? And there is this condition which is called a spongiform pustule of Kogo, in which is neutrophils, which is retained in the stratum spinosum. And last, which is given is Monroe's micro abscess, which you can see in the stratum corneum. That would be enough for you to make the diagnosis. Then the body surface area, if if less than 10 surface is involved, you give a topical therapy. If more is involved, you can give the phototherapy or systemic therapy. Most of the times you will not be asked the questions based on the drugs of systemic therapy, but I've just kept for your understanding that methotrexate can be given in plaque psoriasis or erythrodermic psoriasis or psoriatic psoriasis. I'll not be getting into the detail of it, okay, because rather we stick to things which can be asked in the exam. This I said you already. In pregnancy, impetigo herpetiformis. Okay. So in pregnancy, if it comes, the condition which is particularly called which psoriasis, which type of psoriasis which we discuss? Can anyone repeat? Yes, I'm waiting for your answers. In pregnancy, again, you give systemic steroids. Okay, Anirudh, then you go back to your Telegram channel, and I hope the updated notes will be given there to you. Okay. How many of you are willing to take a break? All of you had dinner, right? Or not yet? Yes, absolutely, Doxyan. Okay, Pranjal, fine. Then phototherapy, you can give narrowband UVB, okay, and biologics. I will suggest you stick to the variants and the images. Don't go into the treatment part so much. That won't be asked. Also, always top up your RR sessions with PYQs, because that is going to help you more. Most of the times, the repeated questions come only in exam. Now we move to lichen planus, as everyone has been telling for so long. What kind of surface is involved? Is it extensor or flexor in this? It's chronic immune mediated inflammatory disease of skin, hair, and mucosa, and there will be nail changes. Flexor involvement, absolutely right, Jyoti, Nidhi 5 word, whatever. So the clinical features is very important. We have what? We have the 6 P's in this. What are these 6 P's? They stand for purple, polygonal, papules, plaques, pruritic, and plain top. So they are plain top. These are all the 6 P's which you have to remember. So the type and shape of the lesions is papules and plaques are present. Okay, shape is polygonal, and if you purple color in nature, and these are pruritic. So patient is going to tell that that's not in the 6 P's, Jyoti, but that is one finding of the nail. and they have a plain top. Okay, that is what you have to know about the 6Ps. So if you can see, they are slightly purple in color and they are polygonal. They are papules and plaques, itchy condition, and they are plain top. So these striations are present. Okay, reticulate web-like striations are present. This is called as Wickham striae. So this net-like or web-like which is present is called as Wickham striae. So that is also very classical for lichen planus. And next, what we have to know is the distribution. What kind of distribution? We discussed this already. We just finished it, wrapped it. The flexar surfaces are involved, and true Cobner is again present here. Keep this repeating. Like where else we discuss true Cobners? This is a revision session. So comment down in the comment section, what all places you saw true Cobners. Then you have the oral lesions, which are present in 40 to 60% of the patients of this condition, where it is some reticulate pattern, lacy pattern, which is seen, the white lacy reticulate pattern, which is seen. In the nails, you can see these lines, which is just telling you the thinning of nails is present. Then we have this triangular band-like structure which is there, which is pterygium. Some of you already told about this, the pterygium. Fine. Then scarring alopecia, which we discussed initially in the classification, that is enough to do. In this, the hair is like the condition is lichen planopilaris. Then we have these histopathological images, which we have to remember about the lichen planus. Sometimes they give a clinical case history and they just give two images, one of the lesion, and then they add the histopathological image as well. So there is a wedge-shaped granulosis which is seen in them. So there is a wedge-shaped granulosis which is seen. Civet bodies or colloid bodies can be seen, and you can see saw-toothed rete ridges are present. So these are elongated like teeth. Okay. Then there is band-like lymphocytic infiltration, which is seen. What treatment we can give? Limited disease. If it is a limited disease, we can give topical steroids. So if it is not infection, so many conditions in dermatology we can treat with steroids. And that's why I told the story of the pharmacist giving steroids, because they think that everything in dermat can be treated with steroid. Okay, so what is tinea incognito? That reminds me of tinea incognito. Can anyone answer? Tinea incognito. This is a PYQ, tinea incognito, of your FMG exam. So let me check if you actually heard it. Waiting for your responses. No center, I would rather say no central clearing in that. So why we are calling it as incognito? Because this is not presented as that classical tinea infection, which should be the annular plaque which is there. Not abrupt stopping of steroid. Rather, there is a history of steroid usage. So if topical steroids, patient is applying topical steroid and it is a tinea infection, ideally someone should have prescribed azoles, topical azoles to the patient. But now the topical azoles was not given. And the pharmacist, that's what the story I told. The pharmacist gave the steroid, topical steroid, and it changed its appearance. So this became a secondary lesion where there was no central clearing. Now, do you understand? Even there is no improvement initially as well. From where dermatophytosis is coming? I have been asking, about the tinea incognito variant. So I told you that don't forget that incognito is because you cannot recognize this is a tinea infection because it has changed its appearance. So it is secondary kind of a lesion. It has become secondary because of the topical steroid application. Otherwise, you can give. Okay, so let's not move away from the topic. Go back and revise. So, limited disease, you use topical steroids and then you use systemic steroids. Now, another condition which is Pityriasis rosea. Anyone who can tell me the meaning of Pityriasis, word Pityriasis? So, word Pityriasis means so it's for scaling, and rosea is for that rose, the reddish appearance. Okay, what happens is like I would like you to remember it like a story. So there is a herald patch. You have to remember in Pityriasis rosea. Focus on the words which I'm telling. Herald patch, which is a mother's patch. So this one single patch comes first, and then it is followed by other lesions. Okay. Then there is a Christmas tree pattern. Now, what you have to remember, the places where Christmas is celebrated, there is a mother whose name is Rosie. Okay, try to remember it like this. So Pityriasis rosea. So rosea, Rosie, the mother. So mother is going to remind you of herald or mother's patch. And what happens is the etiology is HHV7. This is a self-limiting papillosquamous condition, and it is acute. Mostly, there is a lesion. There's a colorate of scale, because if you can see this lesion, it appears like as if the lesion is having a collar-like appearance. Okay, that is colorate of scales. So this is your Christmas tree pattern. So I hope this story can help you remember this. Rosy Mother. Why Rosy Mother? Because places where Christmas is celebrated. So Christmas tree pattern, Pityriasis rosea, colorate of scale is there, and distribution is along the lines of Langer's. But most important points I would say are only these: the herald patch, colorate of scales, and this can be given as image to your question. And it is again self-limiting papillosquamous eruption. Okay, so try to remember the most important points now. Then you have a Pityriasis rubra pilaris. Pilaris is for your uh, hair follicle. Okay, so this you can see there is some island of hypopigmented area which you can see, and this pilaris is seen like this, the nutmeg greater appearance. If you have seen a nutmeg, this appearance like this exactly island of sparing is seen. Okay, so the region is involved, but then there is a certain place where the lesions are not there. So there is an island of sparing which is present, and there is a checkerboard a pattern which is there. But I would stay just focus more on Pityriasis rosea. If they can ask you that, they are going to ask you Pityriasis rosea. Then we move to histamine related mediated disorders. I guess all of you have seen urticaria at least, right? Most of the people have this urticaria, like some, like at least have seen probably. Urticaria is uh, actually what happens here is special lesion of urticaria is a wheal. So this is a special lesion. How you can identify this lesion, the wheal? So there is a central paler which is there, and peripheral erythema. If you can see, notice slight pinkish. So there is a peripheral erythema with a central paler. What is important is it is itchy and the wheels are transient in nature. So they can come, they can go off automatically. So this is just allergies. So usually people feel like they took a medicine and they got these wheals, urticarial rashes, and then this urticarial rash just went fine. Okay, that kind of condition it is. Then there is an exaggerated response, which you can see. Derma is for skin. Okay, when you write. So when you scrape the skin of urticarial people with a blunt object, this kind of a sign is elicited, which is called as dermographism. So this pink thing you can see right here. Next, what you have is angioedema. Okay, in this, what happens is maybe it is also there is a history of taking some eating some food, probably peanut allergy, probably, or something else, or some medicine or some drug reaction can happen like this. There is a subcutaneous or submucosal edema which is there, and most of the times the lip and the face is involved here. So that is all about angioedema. Then we have a cutaneous mastocytosis. Mast cell proliferation is there. So the mast cells, because mastocytosis word is going to tell you the mast cells are involved. So you can see the lesions, the hyperpigmented lesions, which has the metachromatic granules. Okay. So they have a Derrier sign positive. Anyone who can answer me what is a Derrier sign? I'm waiting for your responses. Then in the end, we have hereditary angioedema. Okay, and what is in this is a hereditary condition. What kind of hereditary inheritance pattern is there? It is an autosomal dominant kind of inheritance pattern. So what happens in them is there is a deficiency of C1 esterase enzyme. So this is deficient, that causes hereditary angioedema. This is a non-pitting type of edema. So edema comes. So I hope you understand what is a pitting edema and versus a non-pitting edema. Again, also you think of recurrent episode. So there are recurrent episode. Patient will come and tell you that he or she has this appearance of edema which comes and goes. So this is most likely this. Yes, pseudo ephedrine hydroxy. Very difficult name. Absolutely right. So let us move to eczema on the basis of duration, like when it is presented. The type of lesion particularly, we have acute, subacute, and chronic. Where does lichenification happen? Can anyone tell me? In acute, we will have all signs of acute. Vesicles will be there, erythema will be there. So you will be able to just see it with the image. There will be vesicles, vesicular rash, which will be present. Erythema will be there. Okay. Fluid filled lesions. Where is lichenification happening? In out of these three, acute versus subacute versus chronic. So just common sense. Chronic. Is eczema itchy? Does patient has itching in eczema? Chronic has lichenification, right? I guess Prem Kishore wants to answer that. Lichenification is there because of the itching. Patient is going to continuously scratch the site of eczematous lesion. So if this is there, there will be lichenification, there will be scaling, which you can see. On the basis of etiological classification, you can have exogenous and endogenous type of eczema. So let us study first the exogenous variant, where you can have irritant contact dermatitis and allergic contact dermatitis. So what happens is some exogenous source is coming. Fine. So irritant is restricted to the site of contact. So there is some irritant which is causing this condition, the irritant contact dermatitis. So it can be because of any chemicals, right? Any detergents, acids, bases. So this is causing direct damage to the skin, which is causing your irritant dermatitis. One such example is diaper dermatitis, which can be seen in babies. So the diaper, the cloth, whatsoever is causing these rash. Okay, so this is going to be present in all kinds of people, because if it is an irritant, everyone is going to be get infected. Versus if you compare with allergic dermatitis, in cases of allergy, it is going to be present in only individuals who are allergic to that kind of a chemical. So type for hypersensitive reaction, it is the allergic contact dermatitis is type 4. Okay, then it is going to disseminate. It is not going to just stay to that particular site where it is, where the allergen is going to come into contact. Okay, so there are some common examples. As we saw, the example of irritant dermatitis is one is the diaper dermatitis, and the example for allergic contact dermatitis is nickel, cement, bindi, hair dye. We have already discussed bindi and even the hair dye thing. So if you can see, the scalp will be involved, and the uh, forehead areas will also be included. Can anyone tell me what is PPD and what is PTBP in bindi? Because I've taught you already, so let us just revise that. PTBP is PPD. We have not discussed. Para tertiary terata. Prem Kishore, good try. Paraphenylene diamine, absolutely. So PPD is paraphenylene diamine. That's what I've got from answers. PTBP is para tertiary butyl phenol. Absolutely right. Then the investigations. Okay, investigations, you can you can do a patch test for allergic contact dermatitis. So you just put the allergen here and you apply it to the back. So they have asked it previously, by like they have given this image and asked, first thing is, when do you take the first reading? At 48 hours. But if they ask you best reading, when they should take, at 96 hours. So two things you take from here. One, that image, if they directly give you this image, some patch is applied to the back, then it is the patch test of allergic contact dermatitis. And the second thing, the 48-hour reading and the 96 hours is the best time for that. Okay, I hope this much is clear to you. So let us now move to the airborne, other exogenous kind of a variant. Okay, because obviously the airborne contact dermatitis, this plant is also exogenous in origin. So this is caused by your Parthenium hysterophorus, also called as Congress grass. Okay, so what is the allergen in it? You have to remember this as well. Cisquiterapene lactone is the allergen, and so this is airborne because this Congress grass throws this cisquiterapene in the air, which can cause you this kind of infection. Then we further move to the next kind of eczema, which is your endogenous eczema. So endogenous, the seborrheic dermatitis. So probably you might have had seborrheic dermatitis. Okay, so many people get the seborrheic dermatitis thing. This is an inflammatory response to the Malassezia furfur infection. Okay, and this is present in the seborrheic areas of the body. That is why the seborrheic dermatitis. Over the scalp, you can see the cradle cap. Someone was giving me answers when we were reading Tinea capitis. Tinea capitis, where that we saw a scutula was there, but cradle cap is here. Okay, I don't know, maybe Jyoti or someone was saying that. So please, don't confuse these things. This is a cradle cap of a child. Infant with seborrheic dermatitis will come as this cradle cap thing, where the yellow crusting will be seen over the head of the baby or the scalp of the baby. So greasy yellow scales will be there. Okay, this is cradle cap. So don't confuse it with scutula of tinea. Okay, Then you have over this areas, the nasolabial areas and the beard area. Next, we have compare it with stasis and gravitational eczema. It is seen in people with chronic venous insufficiency. So you have to just know the name of SEEP classification, which can be done for this. And there will be pigmentation, which can be seen along with the eczematous rash, which is there, which is also pruritic. Then next we have Pityriasis alba. What is the differential diagnosis? I told you somewhere, I just taught you Pityriasis alba. Pityriasis again means scaling. So there was a hypopigmented lesion which we read. Can anyone tell me? Hypopigmented scaly macules present on face. I need your last push. We are about to finish. Some more pages are there. Who would like to solve also previous year questions with the session like after this? We can go for a short break as well if you are very tired after this eczema thing. Yes, no, vitiligo, not the answer. Pityriasis alba, I taught you as a differential diagnosis. In some leprosy, we just started our session with that. Go back and try to find it before our next session. Then we have nummular or discoid eczema. See, you have a hypopigmented macule present on the face in the children. Nummular or discoid eczema, you can see coin-like lesion which is present where the center is active and the periphery both are active. Okay, that is the nummular or discoid eczema. This is exactly given this like this in image. And then there are vesicles. If there are deep seated vesicles present on the palms and soles, this is Pemphigus type of eczema. Fine. Next, we move to the atopic dermatitis. Yes, Pranjal, absolutely right. But what particular type of Hansen's? Atopic dermatitis, you look for history of atopy. So what happens is this child, probably this child will be visiting to the ENT doctor, to the dermatologist as well, and to the respiratory medicine specialist as well. Why? Because there is a atopic triad which is happening because of the type 1 hypersensitivity reaction. There is atopic dermatitis in them, atopic asthma, and allergic rhinitis. Okay, so these are the three things, they come as a triad. So in infants it can happen in less than 2 years of age. So the area which is involved is face, scalp, and extensors when it comes to infants. But when it comes to childhood, the areas which are involved is flexural surfaces of the body. Okay, and lichenifications of the flexures, because in adults is going to happen because if they do the itching. Jyoti, absolutely right. Indeterminate leprosy. That time I told you that differential diagnosis is Pityriasis alba. So Pityriasis is again scaling. Is scaling is there in Pityriasis alba, but is in indeterminate leprosy scaling is absent. That's what we need to remember. Okay. Then one of the criteria which is used, Hannifin and Rajka criteria for the diagnosis of atopic dermatitis, where itching is there, pruritus is there, okay, then personal or family history of atopy is there. So when you, as I told you that this atopic dermatitis kid will be visiting different OPDs, which ENT specialist for allergic rhinitis, for asthma, he might be going for the respiratory medicine specialist, and for atopic dermatitis to the dermatologist. So the key diagnostic criteria includes the pruritus and the personal or the family history of atopy. So his mother or father or someone in the family will have the same kind of features as well. Then what we have is a white dermographism. Just compare it with the dermographism, which was exaggerated response in case of urticaria, where the lines of the trauma, they were pinkish, but here this is white. So white dermographism is a feature of atopic dermatitis. Okay. And is this a headline site? Is this a Derry Morgan fold? Anyone who has read it previously? Because I just want to check if you're not sleeping. So because they have itching, they will rub their eyes. They have this allergic rhinitis is a condition where the itching happens overall. Like here also the patient is going to do a lot of itching here and there. Eyes will have itching. Anyone? So this is going to lead to a condition which is called as Denny Morgan fold. You can see there are many folds which is present on the lower eyelid which can be seen, and a headlight sign because the baby has turned pink. The both malar areas are pink, which is looking like a headlight. So this is headlight sign. Okay, creases are present on the lower eyelid. Absolutely correct. Then we give topical steroids or emollients to the patients, and we can go systemic steroids can be given. Okay, that is vesiculobullous diseases. We can take it after a break of 10 minutes, and after this break, we are also going to uh, actually take the PYQs as well. Okay, so join right after 10 to 15 minutes. We are going to take the vesiculobullous diseases and a little more, and then the questions. Okay, Jyoti have had headlight sign herself. That's sad. So someone in your family also have this atopic dermatitis finding, Jyoti, or such kind of a condition. So we have a student who has a similar condition. So probably she can also help in teaching this condition. Okay, let's come after a break, 10 minutes.